Welcome, future nurses. In this session, we are going to open our eyes, literally and clinically, to the fascinating world of eye disorders. Vision is one of the most vital senses, and even minor eye problems can drastically affect a client's independence, safety, and quality of life. As nurses, your role goes far beyond administering medications. It includes careful assessment, prevention of complications, teaching proper eye care, and providing emotional support to clients facing vision loss. Today, we will explore common eye conditions, priority nursing interventions, and high-yield NCLEX strategies that will empower you to protect and promote your patient's vision. By the end of this lesson, you will feel more confident in recognizing eye disorders and providing safe, effective, and compassionate care. Before we dive into the topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep, interactive live classes, and easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, eBooks, and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail during comprehensive lecture. This isn't just another review, it's everything you need in one. Please scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Let us shift into another critical NCLEX scenario that highlights emergency nursing priorities. Imagine this: a 16-year-old high school chemistry student rushes to the school nurse after being splashed in both eyes with an unknown chemical solution during a laboratory experiment. The student is anxious, reports burning pain, and struggles to keep the eyes open for long. The nurse must decide what information is most urgent to obtain before moving forward with interventions. Here are the options to consider. Option A, whether the student was wearing safety goggles at the time of exposure. Option B, the exact name and chemical composition of the substance involved. Option C, what first aid or irrigation measures were provided at the scene before arrival. And option D, whether the student's vision is currently blurred or impaired. The correct answer is option C, what first aid or irrigation measures were provided at the scene before arrival. This is correct because the single most urgent priority in ocular chemical burns is to confirm and continue irrigation. The outcome for vision depends largely on how quickly and thoroughly the chemical is diluted and flushed away. Knowing whether irrigation with normal saline or even plain water was started, and for how long, directly determines the next steps. If irrigation has not yet been done, the nurse must initiate it immediately, even before obtaining a full history. Every second counts because prolonged chemical contact can lead to scarring, corneal perforation, or even permanent blindness. Now, let us look at why the other options are not the priority. Option A, whether safety goggles were worn, may be relevant for documentation and liability, but it does not change immediate management. The focus is on saving vision, not assigning responsibility. Moving on to option B, the exact name and chemical composition of the substance. While useful to predict severity, since alkalis penetrate more deeply than acids, this should never delay irrigation. Flushing the chemical is the universal treatment, and waiting for identification could cause worsening injury. Finally, option D, asking whether the student's vision is blurred or impaired, is certainly part of the assessment but not the initial priority. Visual testing can be performed after irrigation has begun. Prioritizing vision assessment over flushing could compromise long-term ocular outcomes. To integrate this into clinical practice, remember that chemical eye burns are true ophthalmic emergencies. Nursing actions must prevent further absorption and penetration of the chemical. Guidelines recommend immediate and continuous irrigation for at least 15 to 30 minutes or until ocular pH is normalized. Special caution is needed with alkali exposures like ammonia, lime, or lye, as these penetrate rapidly into deeper corneal structures. Nurses must also avert the eyelids to remove any trapped particles during irrigation. And here is your Stancoast Pearl. In chemical eye burns, seconds save sight. Do not delay for chemical identification or vision checks before confirming irrigation. The top priority is to establish what emergency care has already been done, so you know whether to continue or urgently restart irrigation right away. Let us move into another urgent NCLEX emergency care scenario. A 16-year-old student rushes into the school nurse's office after a chemical accidentally splashed into the eyes during a laboratory experiment. The student is in distress, reporting burning pain, tearing, and difficulty keeping the eyes open. The nurse must act without delay and prepares for immediate ocular irrigation. The question is, assuming the following solutions are available, which is the best choice to use at this time? The options include tap water, sodium bicarbonate solution, normal saline, and magnesium sulfate solution. The correct answer is option 1, tap water. Here is the reasoning. In cases of chemical eye exposure, the very first and most important nursing intervention is immediate and copious irrigation. The priority is to dilute and physically remove the chemical from the eye surface to prevent deep tissue penetration and permanent corneal damage. Tap water is universally accessible in schools and community settings and should never be delayed while waiting for something more ideal. Even though tap water is hypotonic and may cause minor corneal edema, this effect is minimal compared to the devastating injury caused by delaying irrigation. Both the American Academy of Ophthalmology and Emergency Nursing Guidelines emphasize that every second counts in chemical burns, time equals tissue, and quick irrigation can be the difference between saving and losing vision. Now, let us examine why the other options are incorrect. Sodium bicarbonate solution may sound like a neutralizer, but it is not recommended for routine ocular irrigation and can worsen the injury if used blindly. Neutralizing agents should never be applied without knowing the exact chemical involved, because attempting to neutralize an acid with a base, or vice versa, risks creating exothermic reactions that burn the eye further. Normal saline is considered the ideal irrigant because it is isotonic and non-toxic to ocular tissues, but in real emergencies, it is rarely available in the large quantities needed in a school or community setting. If it is ready immediately in sufficient volume, it is excellent, but waiting for it only wastes critical time. Magnesium sulfate is completely inappropriate here. It is hypertonic, irritating to the cornea, and can cause cellular toxicity, worsening the damage instead of helping. To summarize the key points for NCLEX preparation, the first aid principle is clear. Immediate and prolonged irrigation is the gold standard for chemical eye burns. In emergencies, accessibility is more important than perfection, which means using whatever safe solution is available right away. Irrigation should continue for at least 15 to 30 minutes, or until the ocular pH normalizes. And the ultimate outcome depends more on how fast irrigation begins than on which specific solution is chosen. And here is your Stan Coast Pearl. In chemical eye burns, the best solution is the one you can start with immediately. Never delay irrigation. Vision depends on seconds, not solutions. Let us now dive into another high-priority NCLEX emergency care scenario. A 16-year-old student presents to the school nurse's office after a chemical splashes into the right eye during a laboratory experiment. The nurse prepares to initiate ocular irrigation using sterile normal saline. The question asks, which steps are the correct nursing actions to ensure safe and effective irrigation of the affected eye? Select all that apply. The available options are placing the irrigating solution directly into the center of the eye, tilting the head toward the opposite eye, performing hand hygiene and applying clean gloves, offering the client tissues or patting the shoulder area for drainage, directing the solution into the conjunctival sac by pulling down the lower eyelid, and continuing eye irrigation until all visible redness has resolved. The correct answers are options 3, 4, and 5. To begin with, performing hand hygiene and applying clean gloves is essential because infection control is always the first priority in any procedure. The eye's natural defense barriers are already compromised after a chemical injury, so hand hygiene reduces pathogen transmission, while gloves protect both nurse and client from cross-contamination. Next, offering the client tissues or patting the shoulder area is a practical step that improves comfort and maintains dignity, since copious irrigation fluid naturally drains across the face and shoulder. Without this preparation, the client's clothing may become soaked, increasing distress and reducing cooperation during an already stressful emergency. Finally, directing the solution into the conjunctival sac by pulling down the lower eyelid ensures that fluid washes effectively across the cornea and conjunctiva. This technique avoids the risk of corneal abrasion and maximizes chemical dilution and removal, protecting delicate ocular structures. Now, let us carefully examine why the other options are incorrect. Placing the irrigating solution directly into the center of the eye is harmful because the cornea is highly sensitive, and direct streams can cause further injury or worsen epithelial damage. Tilting the head toward the opposite eye is unsafe, since it allows contaminated solution to run into the unaffected eye, increasing the risk of additional injury. Instead, the head should be tilted toward the affected side so gravity drains contaminants safely away. Finally, continuing irrigation until all visible redness resolves is misleading, as redness is not a reliable marker for adequacy of flushing. Evidence-based guidelines recommend irrigation for at least 15 to 30 minutes, or until the ocular pH is normalized to between 7.0 and 7.5, measured with litmus or pH paper. Redness may persist even after proper irrigation, so clinical judgment must rely on pH and time rather than subjective appearance. Here is your Stancoast Pearl. In chemical eye exposures, time is tissue. Irrigation must begin immediately, with the safest available solution, the head tilted toward the affected side, and flushing continued for at least 15 to 30 minutes, or until ocular pH normalizes. Waiting for an ideal fluid wastes precious time and risks permanent corneal damage. Swift action makes all the difference in preserving vision. Moving on to another high-priority emergency scenario, let us consider the case of a client in the emergency department whose eyes are being irrigated following a chemical injury. The question asks, which technique best describes the proper direction of the irrigating solution to ensure both safety and effectiveness? The available options are as follows. Option 1 suggests directing the stream of solution directly onto the corneal surface. Option 2 recommends allowing the solution to flow from the inner canthus toward the outer canthus. Option 3 proposes instilling the solution within the anterior chamber to flush out contaminants. Option 4 suggests aiming the solution toward the nasolacrimal duct at the inner canthus. The correct answer here is Option 2. Allow the solution to flow from the inner canthus toward the outer canthus. Now let us break this down carefully. The reason Option 2 is correct is because irrigating in this direction prevents contaminated solution and chemical residue from flowing into the unaffected eye. It also protects the nasolacrimal duct from absorbing harmful chemicals into the nasal mucosa and systemic circulation. Furthermore, this technique ensures the solution effectively clears debris from the conjunctival sac while protecting the cornea from unnecessary trauma. It represents the safest, most anatomically sound, and most clinically effective method of emergency eye irrigation. Turning to why the other options are incorrect, Option 1 is unsafe because the cornea is highly sensitive, and directing fluid directly onto it can cause pain, reflex blinking, or microtrauma, reducing the effectiveness of the procedure. Next, Option 3 is not feasible because the anterior chamber is an internal ocular structure, located behind the cornea and iris. Flushing it is a surgical or intraocular intervention, not part of emergency irrigation. Finally, Option 4 is unsafe because directing fluid toward the nasolacrimal duct at the inner canthus risks systemic absorption of harmful substances and increases the chance of spreading injury into the nasal cavity or bloodstream. Clinically, the key integration point is that safety always comes first. We protect the unaffected eye, avoid direct corneal trauma, and prevent systemic absorption. From a test-taking standpoint, students should immediately eliminate answers that describe intraocular procedures or unsafe fluid directions. Remember this Stancoast Pearl. Think in to out. In eye irrigation, always start from the inner canthus and flow outward. This protects the other eye, spares the nasolacrimal duct, and ensures safe, effective cleansing. Let us now move into another advanced NCLEX-style scenario that challenges your understanding of interdisciplinary care. Imagine this case. A 15-year-old student sustains a chemical splash injury to the eye while working in a school laboratory. The client receives immediate irrigation in the emergency department and is stabilized. At the time of discharge, the nurse must ensure proper follow-up to prevent long-term complications. The question asks, which professional is best suited to provide follow-up care? Here are the options. Option 1 is an optician. Option 2 is an ophthalmologist. Option 3 is an optometrist. And Option 4 is an orthoptist. The correct answer is Option 2, an ophthalmologist. An ophthalmologist is a medical doctor, either an MD or DO, who specializes in both the medical and surgical treatment of eye diseases. Chemical eye trauma carries risks that extend far beyond the immediate emergency, such as corneal scarring, secondary glaucoma, cataract formation, or even progressive vision loss. An ophthalmologist has the training and tools to monitor these delayed complications using slit lamp examinations, intraocular pressure assessments, and imaging techniques. They are licensed to prescribe advanced pharmacologic agents such as corticosteroids, antibiotics, and cycloplegics, as well as perform surgical interventions like corneal debridement or transplantation if necessary. Thus, follow-up with an ophthalmologist ensures that the client receives the highest level of comprehensive care, preventing blindness and preserving long-term visual function. Looking at the other options, an optician, described in option 1, is primarily a technician who fabricates and dispenses eyeglasses or contact lenses based on prescriptions from ophthalmologists or optometrists. While their role is important in vision correction, they do not have the authority or expertise to diagnose or manage injuries. This makes them irrelevant in managing chemical trauma. Moving to option 3, the optometrist. This professional does have training in evaluating visual acuity, prescribing corrective lenses, and managing some uncomplicated eye conditions. However, they lack the surgical expertise and advanced medical management skills required in cases of chemical injuries. In situations where complications like corneal opacities or glaucoma develop, they must refer the client to an ophthalmologist, making them insufficient as a sole follow-up provider. Finally, option 4, the orthoptist, is a specialist who focuses on binocular vision problems, strabismus, and eye movement disorders. While they often collaborate with ophthalmologists, their role is very specific to muscular imbalance and coordination, not chemical trauma. Therefore, they are not appropriate for follow-up in this situation. Here is the clinical insight, also known as the Stan-Coast Pearl. Chemical eye injuries are considered true ophthalmologic emergencies. While irrigation is the immediate life-saving step for the eye, the real battle for vision is one with long-term follow-up under an ophthalmologist to prevent blindness from complications such as corneal scarring or glaucoma. Let us now explore another complex NCLEX-style scenario that tests your ability to apply both safety and clinical reasoning. A 32-year-old factory worker comes into the emergency department after a metallic foreign body became embedded in his left cornea while operating heavy machinery. He reports severe eye pain, tearing, and blurred vision. On inspection, the nurse notes a visible metallic speck lodged in the cornea, along with redness and continuous lacrimation. The question asks, before referring this client for ophthalmologic emergency treatment, which immediate nursing action is the most appropriate? Here are the options. The first option is to attempt to carefully remove the object with sterile forceps. The second option is to encourage the client to blink rapidly in hopes of dislodging the particle. The third option is to instill antibiotic ointment into the affected eye. And the fourth option is to loosely patch both eyes with sterile dressings. The correct answer is option 4, loosely patch both eyes with sterile dressings. This intervention is essential because it minimizes extraocular muscle movement, prevents blinking, and protects ocular structures until an ophthalmologist can safely remove the foreign body. Covering both eyes, not just the affected one, is critical since eye movement occurs in unison. If one eye moves, the other moves as well. Attempting removal with forceps outside of a controlled surgical environment is dangerous, as it may drive the object deeper or cause permanent damage. Encouraging rapid blinking only worsens mechanical trauma and increases epithelial abrasions without removing the embedded object. Instilling antibiotic ointment is premature because it interferes with ophthalmologic visualization and does not address the immediate risk of deeper injury. From a safety and risk reduction perspective, the nurse's priority is to stabilize and prevent further harm until specialized care is available. Clinically, this action also aligns with the ethical principle of non-maleficence. Do no harm. Always remember the Stan-Coast Pearl. When something is stuck in the eye, do not touch, do not remove, just protect and refer. Always patch both eyes to prevent movement and save vision. Let us now continue with another NCLEX-style practice question that highlights both nursing knowledge and clinical reasoning. A nurse is preparing to assess a client's vision before the physician conducts a comprehensive eye examination. The nurse explains that the Snellen chart will be used during this assessment. The client then asks what to expect. Which of the following statements shows the most accurate understanding of this procedure? Here are the options. The first statement is, you'll read words that are the size of newsprint. The second statement is, you'll read letters from a distance of 20 feet, or about 6 meters. The third statement is, you'll look at a color picture and identify an image. And the fourth statement is, you'll look at a screen and tell me when an object appears. The correct answer here is option 2. You'll read letters from a distance of 20 feet, or about 6 meters. Now, let me walk you through the reasoning. The Snellen chart is the most commonly used tool for measuring far vision and visual acuity. It contains large block letters arranged in decreasing size, and the client is placed exactly 20 feet, or 6 meters, away in a well-lit environment. Each eye is tested separately, while the other is covered. This standardized distance ensures that results can be accurately compared with normal expectations. Normal vision is recorded as 20/20, meaning the client sees at 20 feet what a person with normal sight should see at the same distance. For instance, a result of 20/40 indicates that the client must stand 20 feet away to see what a normal eye could see from 40 feet. Because of this, option 2 is correct as it directly describes the use of the Snellen chart. Turning to option 1, you'll read words that are the size of newsprint. This is incorrect because it refers to near vision testing. For near vision, nurses use a Jaeger chart, which is held about 14 inches or 35 centimeters away. Unlike the Snellen chart, the Jaeger chart involves smaller words or print size rather than block letters for distance. Next, option 3, you'll look at a color picture and identify an image, is also inaccurate. This refers to color vision testing, usually performed with Ishihara plates, which assess for red-green color deficiencies by having clients identify numbers or patterns within colored dots. This does not test visual acuity. Finally, option 4, you'll look at a screen and tell me when an object appears, is incorrect because it describes a peripheral vision assessment, often done using a tangent screen or automated perimetry. This is useful for detecting glaucoma or neurological issues, but it does not measure far vision acuity. From a clinical standpoint, measuring visual acuity is one of the most basic yet critical parts of any eye examination. It helps detect refractive errors such as nearsightedness, farsightedness, or astigmatism, and serves as a baseline for tracking changes over time. Abnormal findings may indicate the need for corrective lenses or additional ophthalmologic evaluation. Nurses should also ensure clients clearly understand the procedure, which helps reduce anxiety and promotes cooperation. And here is your Stand-Coast Pearl. Think of 20 feet for the Snellen chart. If the test involves close-up reading, it is the Jaeger chart. If it involves color patterns, it is Ishihara. And if it involves side vision, it is a tangent screen. This way, you can instantly link the tool with the purpose. Moving forward into our next clinical scenario, let us consider a client who is scheduled for a retinoscopic examination to obtain a more precise measurement of refractive error. Before this diagnostic procedure begins, the nurse must prepare to instill the appropriate ophthalmic medication. The question is, which drug should the nurse anticipate giving to dilate the pupil and temporarily paralyze the ciliary muscle, thereby preventing accommodation during the test? Here are the options to choose from. The first option is pilocarpine, also known as Pilocar. The second option is dipivefrin, or propine. The third option is gentamicin, marketed as Genoptic. And the fourth option is cyclopentolate solution, which is also known as cyclogil. The correct answer here is option 4, cyclopentolate solution, or cyclogil. Now, let us explore why this is the right choice. Cyclopentolate acts as both a mydriatic, meaning it dilates the pupil, and a cycloplegic, meaning it paralyzes the ciliary muscle. In retinoscopy, this paralysis is critical because it prevents the natural process of accommodation, where the eye changes the shape of the lens to focus on near or distant objects. Without cycloplegia, accommodation would distort the findings, making refractive error measurements inaccurate. By keeping the lens in a fixed position, cyclopentolate allows the ophthalmologist to obtain a precise evaluation. Its onset occurs within about 25 to 75 minutes and can last up to 24 hours, making it highly effective for diagnostic exams. Additionally, it is sometimes used in the management of uveitis, as dilating the pupil helps relieve painful ciliary spasms. On the other hand, pilocarpine, option 1, is incorrect because it is a parasympathomimetic agent that causes miosis, or constriction of the pupil, and stimulates accommodation, the exact opposite of what is required for this test. Pilocarpine is most often prescribed for glaucoma to enhance aqueous humor outflow and lower intraocular pressure, not for diagnostic dilation. Moving to option 2, dipivefrin is also not appropriate here. Although it may induce some pupil dilation as a sympathomimetic drug, its primary action is reducing intraocular pressure in glaucoma, and importantly, it does not paralyze accommodation. Therefore, it cannot ensure accurate retinoscopic results. Considering option 3, gentamicin is likewise unsuitable. This aminoglycoside antibiotic is used only for treating bacterial eye infections, such as conjunctivitis or keratitis. It has no impact on pupil size or ciliary muscle function and would serve no purpose before a retinoscopic exam. To put this into a broader clinical context, retinoscopy is a valuable tool for detecting refractive errors like myopia, hyperopia, and astigmatism. The key purpose of using a cycloplegic such as cyclopentolate is to eliminate accommodation, ensuring results are objective and precise. For nurses, the responsibility goes beyond administering the correct medication. It also includes teaching the client what to expect. The nurse should explain that blurred vision and light sensitivity may occur temporarily, and the client should avoid driving until normal vision returns. For your NCLEX success, here are some high-yield pearls to remember. Cycloplegics, such as cyclopentolate and atropine, both dilate the pupil and paralyze the ciliary muscle, making them diagnostic essentials. Mydriatics, such as phenylephrine, only dilate the pupil but do not prevent accommodation. Miotics like pilocarpine constrict the pupil and are used in glaucoma, not in refraction testing. And finally, antibiotics such as gentamicin fight infection but play no role in refractive exams. Stancoast. Pearl. Always think C for cyclogyl and cycloplegia. Cyclopentolate not only dilates but also freezes accommodation, making it the gold standard for accurate refractive error testing. Let us transition into this scenario with a focus on visual disorders. A 22-year-old university student presents to the ophthalmology clinic complaining of blurred distance vision, frequent squinting, and difficulty seeing the board in class. She explains that her optometrist prescribed glasses which help her see far away. While she has no difficulty reading books up close, the nurse now reviews her health record to document the correct medical term for this visual problem. Which of the following terms best describes her condition? The first option is presbyopia. The second option is amblyopia. The third option is hyperopia. And the fourth option is myopia. The correct answer is option 4, myopia. Myopia, also called nearsightedness, occurs when parallel rays of light focus in front of the retina instead of directly on it. This usually results from an elongated eyeball or increased curvature of the cornea. As a result, near objects remain clear, but distant objects appear blurry. Clients often present with complaints of squinting, eye strain, or difficulty seeing classroom boards, road signs, or presentations. Correction is achieved with concave lenses that help diverge light rays and focus them on the retina. Importantly, progressive myopia can increase the risk of retinal detachment. So, early correction and monitoring are vital. Now, let us clarify why the other options are incorrect. Option 1, presbyopia, refers to age-related farsightedness that develops after 40 due to loss of lens elasticity. It impairs near vision rather than distance vision, and it is not applicable to this 22-year-old client. Option 2, amblyopia, or lazy eye, is a developmental disorder where one eye fails to achieve normal vision despite correction. It arises in childhood due to strabismus or deprivation, but this client demonstrates normal binocular vision with improvement through corrective lenses, making this choice unsuitable. Option 3, hyperopia, or farsightedness, results when light focuses behind the retina due to a short eyeball or flat cornea. Clients see far objects more clearly, but struggle with near tasks such as reading or sewing, which is the opposite of this case presentation. To make this concept memorable for NCLEX, here is a clinical pearl. Refractive errors are the most common vision problems worldwide, and understanding them is essential for accurate nursing documentation. Remember, myopia means near is clear but far is blurry, while hyperopia means far is clear but near is blurry. Presbyopia is simply age-related hyperopia, and amblyopia is a functional loss from abnormal childhood development. And here is your Stancoast pearl. Think of myopia as myopia. The client can clearly see what is close to me, but struggles with what is far away. This quick trick helps you differentiate myopia from hyperopia in exam scenarios. Let us now transition into the next NCLEX-style scenario that connects community resources with nursing practice. A nursing assistant confides to the nurse that a family member has significant difficulty with vision and urgently needs eyeglasses but cannot afford them. The nurse must determine which organization would be the most appropriate evidence-based referral to directly address this vision-related need. Here are the options to consider. Option 1 is the Loyal Order of Moose. Option 2 is the American Legion. Option 3 is Lions Clubs International. And option 4 is the Knights of Columbus. The correct answer is option 3, Lions Clubs International. Now, let us break down why Lions Clubs International is the best choice. This organization is internationally recognized for its commitment to vision and hearing care. Their hallmark initiative, called Sight First, focuses on reducing preventable blindness and increasing access to vision services. Local chapters often provide free or low-cost eyeglasses, conduct vision screenings, and even support access to surgeries such as cataract removal. They also extend help for guide dogs and hearing aids. In this case, referring the family member to Lions Clubs International is both practical and directly aligned with the client's need for affordable eyeglasses. Moving on to why the other options are not correct, let us start with option 1, the Loyal Order of Moose. While this group does engage in community and charitable services, their mission focuses more on children's programs, senior care, and community centers, rather than providing vision care or eyeglasses. That makes them an inappropriate referral in this context. Next, option 2, the American Legion is primarily a veterans service organization. Its main mission is to advocate for veterans' benefits, health services, housing, and reintegration support. While valuable, it does not have a specific focus on providing eyeglasses unless the family member is a veteran eligible for their services. Therefore, it does not match the immediate need described. Finally, option 4, the Knights of Columbus, is a Catholic fraternal service organization known for charitable work, scholarships, and faith-based outreach. Although they do fund some health projects, they lack a structured or widespread program that addresses vision care or eyeglasses. This makes them less suitable than Lions Clubs International in this scenario. From a clinical judgment perspective, this question highlights the importance of cue recognition and appropriate action. The cue here is the family member's inability to afford eyeglasses. The nurse must then apply knowledge of available community resources to select an organization that directly solves the problem, which in this case is Lions Clubs International. Here is the Stancoast Pearl for quick recall. Lions have sharp eyes. So when the NCLEX mentions vision assistance or eyeglasses, always think of Lions Clubs International as the go-to referral for sight-saving services. Let us now walk into another important NCLEX-style scenario that highlights visual disorders. While reviewing the medical record of a client, the nurse notes a diagnosis of astigmatism. When assessing this client's visual experience without corrective lenses, which client statement would the nurse most likely expect? Here are the options to consider. Option 1 says, I see near objects more clearly. Option 2 says, I see a blurry area in front of me. Option 3 says, I see far objects more clearly. And option 4 says, I see two of the same object. The correct answer here is option 2. I see a blurry area in front of me. Now let us expand on why option 2 is correct. Astigmatism results from an irregular curvature of the cornea or lens, which causes light rays to refract unevenly. Instead of converging at a single focal point on the retina, the rays scatter and produce blurred or distorted vision in specific areas of the visual field. Because of this, objects may appear stretched, taller, or wider than they actually are. Unlike conditions such as myopia or hyperopia, astigmatism does not simply make near or far vision clearer, but causes a patchy blur at all distances. Clients often describe difficulty with fine details such as reading small print or seeing straight lines clearly, and driving at night is especially troublesome. Corrective eyeglasses with cylindrical lenses or contact lenses work by redirecting light so it focuses on a single point, thereby restoring clarity of vision. Moving on to why option 1 is incorrect. The statement, I see near objects more clearly, reflects myopia or nearsightedness. in which the eye focuses light in front of the retina. People with myopia can see close objects well but struggle with distance vision. Astigmatism, however, does not give this selective advantage for near vision, but instead creates irregular distortion. Next, let us examine option 3. The claim, "I see far objects more clearly," corresponds to hyperopia or farsightedness. In this condition, the eye is too short or the cornea too flat, so light focuses behind the retina. Clients with hyperopia see distant objects clearly but have difficulty with near tasks such as reading. Again, this is different from astigmatism, which creates inconsistent blurring across all ranges. Finally, we come to option 4. The statement, "I see two of the same object," describes diplopia or double vision, which occurs due to misalignment of the eyes, cranial nerve dysfunction, or neuromuscular issues. Astigmatism may stretch or distort objects, but it does not produce true duplication of images, so this choice is not correct. Here's a clinical insight to tie this together. Astigmatism is one of the most common refractive errors, often found alone or alongside myopia and hyperopia. It can be diagnosed during a routine eye exam using corneal topography or a refraction test. Symptoms include eye strain, headaches, squinting, and blurred vision at all distances, especially in low light. Night vision tends to be challenging because light scatters on the irregular corneal surface. And here is your Stancoast pearl. Remember, think distortion, not distance. Astigmatism causes uneven blur at all ranges, unlike myopia or hyperopia, which clearly favor near or far vision. Let us now move into another NCLEX-style teaching scenario, this time focusing on vision care. A nurse is providing teaching to a client who wears prescription eyeglasses. After demonstrating the correct method of cleaning the lenses with soap and warm water or a commercial glass cleaner, the nurse must emphasize the best action for drying to maintain lens clarity and prevent surface damage. Here are the options for you to consider. Option 1 suggests rubbing the lenses with a paper tissue. Option 2 recommends wiping the lenses with a soft cloth. Option 3 advises blotting the lenses with a paper towel. Option 4 proposes blowing on the lenses to promote air drying. The correct answer is option 2, wiping the lenses with a soft cloth. This is the safest and most effective method because microfiber or other soft lint-free cloths are specially designed to absorb moisture and remove small debris without scratching delicate lens surfaces. Paper products contain abrasive fibers that can create microscratches, and even subtle scratches scatter light, reducing visual clarity and safety. By using a soft cloth, clients preserve the quality of their corrective lenses and protect their long-term vision health. Now, let us analyze why the other options are incorrect. Option 1, using a paper tissue, may seem harmless, but tissues are made from wood pulp fibers that can scratch softer lenses like plastic or polycarbonate. Over time, this leads to permanent damage to coatings such as anti-reflective or UV protection and compromises vision, especially while driving at night. Option 3, blotting with a paper towel, is even more damaging because paper towels are rougher and act like sandpaper on delicate lens coatings, destroying protective layers like scratch resistance or blue light filters. Nurses must teach clients to avoid this common household habit. Option 4, blowing on the lenses to air dry, is ineffective and unsanitary. Breath carries bacteria and proteins that leave streaks and residue, while air drying alone creates water spots that scatter light and reduce clarity, especially dangerous for clients with pre-existing vision impairments. Clinically, this teaching point highlights the nursing role in client education and safety. Improper lens care not only reduces vision, but also increases healthcare costs due to frequent replacements. For older adults and clients with conditions like diabetes or cataracts, even minor visual disturbances can increase fall risk, making proper eyeglass care an essential part of nursing education. Stancoast pearl. Protecting your lenses is protecting your sight. A soft, lint-free cloth is not just about clarity. It is about safety, independence, and preventing long-term complications. Let us now move into a thoughtful scenario that highlights the importance of communication and trust in nursing practice. A nurse is caring for a hospitalized client who is anxious due to temporary vision loss following bilateral eye surgery and the application of eye patches. The key question is, which nursing intervention is most appropriate to reduce the client's anxiety and promote trust during care? Here are the options to consider. The first option is to touch the client gently before speaking to establish presence. The second option is to explain the planned care and procedures before initiating any action. The third option suggests positioning yourself directly in front of the client while speaking. The fourth option recommends keeping the room lights on continuously to enhance orientation. The correct answer is option 2. Explain the planned care and procedures before initiating any action. This is the best choice because clients who are blind or whose vision is obstructed feel anxious primarily due to uncertainty. By explaining what is about to happen, the nurse reduces fear of the unknown, creates predictability, and allows the client to feel more in control. Verbal explanation also builds trust, prevents startle responses, and aligns with the principle of therapeutic communication. For visually impaired clients, hearing becomes the main sense for orientation, making spoken guidance before action essential to safe and dignified care. On the other hand, let us analyze why the other options are not correct. Touching the client without prior explanation, as in option 1, can actually increase anxiety because it startles the client who cannot anticipate what is happening. Professional practice emphasizes speak before you touch to prevent this reaction. Moving to option 3, standing in front of the client is only beneficial for those who are hearing impaired, since they rely on lip reading and visual cues. For a blind client, this positioning provides no reassurance or reduction of anxiety. Finally, option 4, keeping the lights on continuously, may help partially sighted clients, but offers no benefit to a client who cannot see at all. In fact, it may disrupt sleep, worsen restlessness, and increase discomfort. To integrate this clinically, remember that anxiety comes from uncertainty, and the antidote is explanation. For sensory deficit care, nurses must compensate by enhancing other senses, especially hearing, to keep the client oriented and secure. Above all, verbal communication. Before action safeguards client safety, preserves dignity, and builds a therapeutic relationship. Here are the high-yield NCLEX pearls. Always prioritize interventions that enhance orientation and reduce anxiety for clients with visual impairment. Choose communication strategies over environmental changes or unnecessary physical contact. And remember the Stan Coast Pearl. Speak before you touch, explain before you act. Words become the client's eyes. A quick memory trick is to recall the 3 E's for blind clients. Explain, encourage, and ensure safety. Let us begin with this scenario that highlights safety and trust in nursing care. While observing a nursing assistant ambulating a client who is blind, the registered nurse recognizes the need to reinforce safe ambulation techniques. The critical question is, which instruction by the nurse is most appropriate to ensure both the client's safety and sense of security? Here are the options to consider. The first option is to allow the client to take hold of your arm while walking. The second option is to take hold of the client's arm to guide them. The third option is to position the client directly in front of you and slightly to your side. The fourth option is to permit the client to walk independently by your side. The correct answer is option 1, allow the client to take hold of your arm while walking. This is the safest and most therapeutic method, known as the sighted guide technique. In this approach, the client lightly grasps the caregiver's arm just above the elbow while standing slightly behind and to the side. By doing so, the client naturally follows the body cues of the sighted person for direction, speed, and obstacles. This technique builds trust, prevents accidents, and offers a sense of security in an unfamiliar environment. From an NCLEX standpoint, it also reflects Maslow's hierarchy of needs, where safety takes precedence over independence. Rehabilitation specialists and ophthalmology associations endorse this method as the gold standard for ambulating visually impaired clients. Looking at why the other options are incorrect helps us sharpen clinical judgment. Choosing to take hold of the client's arm, as in option 2, reverses the safe dynamic. It causes the client to lose control of their pace and direction, leading to anxiety or imbalance. In the NCLEX context, this violates client autonomy and dignity. Option 3, positioning the client directly in front, is unsafe because the caregiver cannot anticipate or block hazards, leaving the client vulnerable to falls. Option 4, allowing the client to walk independently by your side, might sound supportive of autonomy, but neglects the crucial aspect of safety. Without visual orientation, the client risks collisions, confusion, and injuries. From a clinical insight perspective, 3 high-yield pearls emerge. First, the sighted guide technique is the recommended standard, where the blind client stands slightly behind and to the side, holding the guide's arm at the elbow. Second, safety principles dictate that fall prevention is always prioritized over complete independence in unsafe environments. Third, therapeutic communication, such as narrating steps like "we are turning left" or "approaching stairs," reduces anxiety and enhances trust. For delegation, it is important to remember that while tasks may be assigned to nursing assistants, the registered nurse remains responsible for ensuring proper technique is used. In summary, the best instruction is to let the blind client take the assistant's arm while walking, because this ensures safety, fosters confidence, and upholds dignity. This is exactly the kind of prioritization NCLEX questions often test, where safe, evidence-based practice outweighs less protective alternatives. To continue sharpening your NCLEX preparation, let us consider a scenario involving a client who has recently lost vision due to complications of diabetic retinopathy. The nurse wants to support independence and dignity during mealtime. The key question is, which nursing action is most appropriate to encourage self-reliance when eating? Here are the options to think about. Option A suggests assisting the client by describing the placement of foods on the plate using the clock face method. Option B recommends arranging for a volunteer to feed the client to reduce the burden of asking for help. Option C proposes requesting liquid nutritional supplements, so the client can drink meals instead of using utensils. Option D offers placing the client's meal on disposable plates and cups to minimize cleanup. The correct answer is Option A, assist the client by describing the placement of foods on the plate using the clock face method. Now let me explain why this choice is correct. The clock face method is considered the gold standard for promoting independence in blind clients. By orienting food placement to the face of a clock, the nurse provides the client with clear spatial guidance, such as chicken at 6 o'clock, vegetables at 9 o'clock, potatoes at 12 o'clock. This allows the client to confidently self-feed, maintain autonomy, and preserve dignity. It supports psychosocial well-being while respecting the adult need for self-care. Turning to the other options, Option B may appear helpful but actually undermines independence. Having a volunteer feed the client fosters unnecessary dependence, potentially leading to feelings of helplessness and reduced self-esteem. Option C also misses the mark because providing liquid supplements without client input implies they cannot eat normally, which damages confidence and may compromise balanced nutrition. Finally, Option D is not appropriate because disposable dishware is unstable and more likely to spill, prioritizing staff convenience over the client's independence and dignity. Here is a Stan Coast pearl. When caring for clients with sensory loss, the nurse's goal is not to replace the client's abilities, but to provide adaptive strategies that maximize independence. For blind clients, the clock face method is a high-yield NCLEX concept and a real-life technique that emphasizes both safety and dignity. Let us now move into the next NCLEX-style practice item, which focuses on visual changes in the older adult. A nurse is assessing an older adult client who has a diagnosis of bilateral cataracts. During the review of the client's health history, the nurse anticipates identifying which clinical manifestation as being directly associated with the progression of cataracts. Here are the options to consider. Option A suggests gradual loss of vision. Option B presents a feeling of fullness within the eye. Option C lists ocular pain or discomfort. Option D includes flashes of light. The correct answer is Option A, gradual loss of vision. Now let me walk you through the reasoning behind this choice. Cataracts are an age-related degenerative condition in which the normally clear lens becomes cloudy due to protein denaturation and aggregation. This leads to progressive opacification of the lens, which reduces light transmission and scatters incoming rays. Because this is a slow and chronic process, the hallmark symptom is painless, gradual loss of vision. Clients often describe it as though they are looking through a foggy window or experiencing blurred vision that cannot be corrected with glasses. Other accompanying complaints include glare sensitivity, halos around lights, and difficulty with night driving, which all stem from the progressive clouding. Turning to the option analysis, Option A, gradual loss of vision, is correct because it perfectly matches the pathophysiology of cataracts, a slow, predictable, and painless decline in visual acuity. On the other hand, Option B, a feeling of fullness within the eye, is incorrect because that sensation is typically linked with angle closure glaucoma, where intraocular pressure rises abruptly. Cataracts alone do not cause eye pressure changes during their early or middle stages. Option C, ocular pain or discomfort is incorrect as well, since cataracts do not cause pain. Any eye pain would point toward conditions such as acute glaucoma, corneal abrasion, or uveitis. Finally, option D, flashes of light, is also incorrect because photopsia is associated with retinal detachment or vitreous traction, not cataract progression. From a clinical integration perspective, the NCLEX often challenges you to distinguish between gradual, painless vision loss of cataracts and the acute or painful presentations of glaucoma and retinal detachment. Think of it this way: cataracts equal gradual, predictable loss of vision. Glaucoma equals acute pain, halos, and pressure. Retinal detachment equals sudden flashes, floaters, and curtain-like shadows. Here is your Stan Coast Pearl for quick recall. Remember the 3 Ps of cataracts: painless, progressive, and predictable vision loss. Anytime you see a client history describing slow decline without pain or emergency signs, cataracts should be at the top of your differential. Let us begin this practice scenario with an important question on eye health in the older adult. A nurse is performing an eye assessment on an older adult client during a routine examination. Which clinical finding, if observed, is most characteristic of cataract formation and should prompt further evaluation for progressive visual impairment? The options to consider are as follows. The first option is ruptured blood vessels visible on the sclera. The second option is an irregular contour of the iris. The third option is a whitish or gray opacity visible behind the pupil. And the fourth option is a painless superficial corneal lesion. The correct answer is option 3, a whitish or gray opacity visible behind the pupil. Now, let us carefully walk through the expanded rationale step by step. Cataracts are a progressive condition in which the normally transparent lens of the eye becomes clouded due to protein denaturation and clumping. This lens opacification leads to scattering of light and impaired transmission of visual images to the retina. On inspection, the hallmark sign is a visible change in the pupillary area. Instead of the pupil appearing black, it may look white, gray, or yellowish because the lens has become opaque. This visible opacity directly corresponds to the client's complaint of blurred, cloudy vision, often described as looking through a foggy window. When analyzing the options, let us first consider option 1, ruptured blood vessels visible on the sclera. This is not a cataract sign, but rather a subconjunctival hemorrhage, often caused by sudden increases in venous pressure during actions such as coughing, vomiting, or straining with a Valsalva maneuver. Moving to option 2, an irregular contour of the iris. We note that this usually occurs after surgical procedures, such as an iridectomy for glaucoma or from traumatic injury. Cataracts do not affect the iris, they affect the lens. Looking at option 4, a painless superficial corneal lesion. This is also incorrect. Abnormal tissue or growth on the cornea, such as a pterygium or corneal scar, is not related to cataracts, because cataracts are a lens pathology, not a corneal disorder. That leaves us with option 3, which is correct because a whitish or gray opacity visible behind the pupil is the cardinal sign of cataract formation. To summarize with high-yield NCLEX clinical pearls, cataracts are associated with painless, gradual, and progressive vision loss accompanied by a visible lens opacity. The pupil may appear white, gray, or yellow rather than black. Risk factors include aging, diabetes, chronic corticosteroid use, smoking, trauma, and excessive sunlight exposure. Differentiating conditions is also important for the exam. Acute painful vision loss often suggests glaucoma or retinal detachment. Sudden painless vision loss points to retinal artery or vein occlusion, while gradual painless vision loss with central distortion is typical of macular degeneration. Stan Coast Pearl. Always remember that cataracts mean slow, painless, progressive clouding of the lens, making the pupil appear white or gray and giving the client that foggy window view of the world. Now let us shift our focus to a very common concern in older adults: cataracts. A nurse is conducting discharges teaching with a 72-year-old client who has been diagnosed with bilateral cataracts. During the session, the client asks, "How will I know when it is the right time to undergo surgery?" To answer this, the nurse must recognize which response from the client shows the best understanding of the correct timing for cataract removal. The available options are as follows. The first option is, "I will need surgery when my vision loss begins to significantly interfere with my daily activities and quality of life." The second option is, "I will need surgery once the pain becomes severe and eye drops no longer help." The third option is, I will need surgery when my cloudy lenses become noticeable to others and affect how I look. And the fourth option is, I will need surgery only when the cataracts have reached their maximum density or have fully matured. The correct answer is option 1. I will need surgery when my vision loss begins to significantly interfere with my daily activities and quality of life. Here's the reasoning behind it. Cataract surgery is not an emergency procedure, but rather an elective one. And the timing depends on how much the vision loss impacts the client's independence, safety, and quality of life. Cataracts progress gradually and are painless. So surgery is guided by functional impairments such as difficulty with driving, reading, recognizing faces, or performing self-care tasks. Modern practice emphasizes early intervention when vision loss threatens safety or daily living, rather than waiting for the cataract to fully ripen. This approach reduces fall risk in older adults, promotes independence, and ensures better quality of life. Now, let us consider why the other options are not correct. The second option suggests surgery is needed when pain becomes severe and eye drops no longer help. This is inaccurate because cataracts do not cause pain and eye drops cannot reverse them. Instead, they may only help with other conditions like glaucoma. The third option suggests surgery is guided by cosmetic appearance, but this is not medically appropriate since the true indication is functional vision loss, not how cloudy the eye looks to others. Finally, the fourth option reflects outdated practice. In the past, cataracts were removed only once they reached maximum density. But with modern phacoemulsification techniques, surgery can be performed safely at earlier stages, making it unnecessary and even unsafe to delay. To seal this concept, here are some high-yield clinical pearls. Cataracts are the leading cause of reversible blindness worldwide and are characterized by progressive, painless clouding of the lens that leads to blurred vision, glare, fading of colors, and decreased night vision. Surgery is the definitive treatment, performed as an outpatient phacoemulsification with intraocular lens implantation. Most importantly, the timing is always individualized, based on functional impairment, not cosmetic appearance or cataract density. Early surgery prevents falls, supports safety, and helps older adults maintain independence. Stand coast. Pearl. Cataract surgery is not about waiting for pain or for the lens to ripen. It is about protecting independence. When vision loss begins to interfere with safety, daily living, or overall quality of life, that is the right time to act. Let us move forward into another important NCLEX-style scenario to strengthen your preparation. A client with bilateral cataracts is scheduled for cataract extraction of the right eye, and the preoperative orders include scrubbing the face for 10 minutes on the morning of surgery, withholding anticoagulant therapy, and instilling dilating drops every 15 minutes for 1 hour prior to the procedure. As the nurse carefully reviews these orders, the key question becomes, which preoperative assessment is the highest priority to ensure client safety during surgery? Here are the options to consider. The first option is to assess the client's face for skin lesions. The second option is to verify the time of the last dose of anticoagulant. The third option is to examine the right eye for drainage or discharge. And the fourth option is to check the left eye for signs of strain or fatigue. The correct answer is option 2, verify the time of the last dose of anticoagulant. This is the priority because anticoagulant medications, whether they are warfarin, heparin, or newer agents like apixaban, significantly increase the risk of retrobulbar hemorrhage during cataract surgery. Retrobulbar hemorrhage is a dangerous complication that occurs when bleeding develops in the tight orbital space after anesthetic injection or tissue manipulation, leading to elevated intraocular pressure, compromised optic nerve perfusion, and potentially permanent vision loss. Since cataract surgery is elective, anticoagulants must be withheld for a safe interval based on the specific drug and the client's coagulation profile, often 24 to 48 hours or longer. Confirming exactly when the client last took an anticoagulant allows the surgical and anesthesia teams to proceed safely without exposing the client to catastrophic bleeding. This directly reflects the NCLEX safety category of prioritizing interventions that reduce immediate life-threatening risks. Now, let us examine why the other options are incorrect. First, assessing the client's face for skin lesions is a routine part of preoperative preparation, since the client has been instructed to scrub the face for 10 minutes, but the presence of minor lesions or irritation does not carry a direct, life-threatening risk during surgery. Next, examining the operative eye for drainage or discharge is indeed important because an active infection could contraindicate surgery. However, in the absence of infection signs in the scenario, this does not outweigh the urgency of confirming anticoagulant timing. Finally, checking the left eye for signs of strain or fatigue may provide insight into the client's functional vision impairment, but it is not a critical safety measure that would influence surgical outcomes or immediate perioperative risk. Here is your high-yield clinical insight. The Stand-Coast Pearl. Before eye surgery, always think blood safety first. Anticoagulant timing is more critical than cosmetic appearance, ocular strain, or minor irritation. The greatest risk to the client is retrobulbar hemorrhage, not skin lesions or eye strain. Let us begin with another clinical scenario to sharpen your NCLEX preparation. 1 hour before cataract surgery, the nurse is preparing to instill the prescribed preoperative eye drops, and the critical question arises: where exactly should these drops be administered to ensure both safety and effectiveness? Here are the possible options to consider. The first option is onto the cornea. The second option is at the inner canthus. The third option is at the outer canthus. And the fourth option is in the lower conjunctival sac. The correct answer is option 4, in the lower conjunctival sac. Eye drops should always be instilled into the exposed lower conjunctival sac, which is formed when the nurse gently pulls down the lower eyelid. This placement avoids direct irritation of the cornea, reduces reflex blinking, and ensures optimal drug absorption across the ocular surface. The conjunctival sac serves as a temporary reservoir, allowing the medication to spread evenly and work effectively. To further reduce systemic absorption, especially with drugs like beta blockers, the nurse should instruct the client to use gentle nasolacrimal occlusion by lightly pressing the inner canthus for 1 to 2 minutes. Now let us carefully examine why the other options are incorrect. Instilling drops directly onto the cornea is unsafe because the cornea is highly sensitive and richly innervated. Contact here causes discomfort, reflex tearing, and rapid blinking, all of which can wash the medication away. Additionally, if the dropper touches the cornea, it may cause scratches and abrasions. Shifting focus to the inner canthus, this location is problematic because medication placed here drains quickly into the nasolacrimal duct, increasing the chance of systemic absorption. For drugs such as timolol, this could lead to adverse systemic effects, including bradycardia or hypotension. Considering the outer canthus, this site is ineffective since drops placed here are unlikely to distribute across the eye. Instead, they may remain on the eyelid margin or spill out, leading to wasted medication and reduced therapeutic benefit. From an evidence-based practice perspective, guidelines consistently highlight the conjunctival sac as the gold standard for eye drop administration. It maximizes safety, enhances client comfort, and ensures the medication remains localized. Additional nursing priorities include maintaining a septic technique by avoiding contact between the dropper tip and the eye, instructing the client not to blink excessively after installation, and spacing multiple medications at least 5 minutes apart to prevent drug interaction or dilution. Here is the Stand-Coast Pearl to help you remember. Think SAC for safety. The conjunctival sac is the safest, most comfortable, and most effective place for eye drops. It avoids corneal irritation, reduces systemic absorption, and ensures proper local action. Let us step into our next NCLEX practice scenario with a focus on safe postoperative care. A client is scheduled for cataract extraction, and the nursing team is working together to individualize a standardized postoperative care plan. The key question is, which standing nursing order would be most inappropriate to include in this client's plan of care? Here are the possible choices to consider. The first option is to keep the client's bed in a low position at all times. The second option is to reapply anti-embolism stockings twice daily. The third option is to urge the client to cough every 2 hours while awake. And the fourth option is to assist the client when ambulating in the hall or room. Now, the correct answer here is option 3, urging the client to cough every 2 hours while awake. This is unsafe after cataract surgery because activities that increase intraocular pressure, such as coughing, vomiting, sneezing with the mouth closed, or straining during bowel movements, can put too much stress on the delicate surgical repair. A sudden spike in intraocular pressure may disrupt corneal or scleral incisions, dislodge sutures, or even shift the intraocular lens implant, leading to serious complications such as hemorrhage, delayed healing, or vision loss. Instead of encouraging coughing, The nurse should focus on preventive measures like hydration, stool softeners to avoid straining, and teaching the client to sneeze with the mouth open to reduce pressure. Shifting to option 1, keeping the client's bed in a low position at all times is an appropriate intervention. This simple safety precaution reduces fall risk, which is especially important for older clients who may have blurred vision, dizziness, or balance issues after surgery. Preventing falls not only protects the client from trauma, but also helps avoid a sudden rise in eye pressure. Moving on to option 2, reapplying anti-embolism stockings twice daily is also correct and should remain part of the care plan. Post-operative clients are at risk of venous thromboembolism due to decreased mobility, and the stockings help promote venous return, prevent stasis, and reduce the risk of deep vein thrombosis or pulmonary embolism. This is a critical preventive measure for overall post-operative safety. Finally, option 4, assisting the client with ambulation in the hall or room is another appropriate order. Clients recovering from cataract extraction often have temporary blurred vision, balance disturbances, or dizziness from eye shields or medications. Ambulating with assistance ensures safety, prevents falls, and at the same time promotes circulation, cardiovascular health, and pulmonary function. Here's your clinical insight, or as we call it, the STANCOAST Pearl. After cataract extraction, the #1 nursing responsibility is preventing any activity that raises intraocular pressure. Even simple movements like bending forward or lifting heavy objects can put stress on the healing eye. Nurses should educate the client to avoid rubbing the eye, sneezing forcefully, or straining during elimination. The ultimate goal is to protect the surgical repair and preserve vision by minimizing stress on the eye during the critical post-operative period. Let us now explore a high-priority NCLEX scenario to strengthen your understanding of post-operative complications. After cataract surgery, a client suddenly reports experiencing severe, persistent pain in the operative eye, accompanied by mild nausea. Which nursing action takes the highest priority in this case? The options provided are: first, report the finding immediately to the surgeon or charge nurse. Second, administer the prescribed analgesic for postoperative pain relief. Third, assess the client's pupil response using a pen light. And fourth, reposition the client to the operative side for comfort. The correct answer is option 1, report the finding immediately to the surgeon or charge nurse. Here's the rationale explained in detail. Severe pain following cataract surgery is never considered normal and signals a red flag for potentially sight-threatening complications, such as hemorrhage, acute glaucoma, or dangerously increased intraocular pressure. Normally, mild discomfort, itching, or a scratchy sensation may occur, but intense pain with nausea strongly suggests abnormal pathology. Uncontrolled intraocular pressure can impair circulation to the optic nerve, leading to irreversible vision loss if not addressed urgently. By reporting these symptoms without delay, the nurse ensures timely evaluation and interventions such as ocular pressure lowering medications, further surgical assessment, or steps to prevent rupture of the surgical site. This follows the NCLEX principles of safety, early recognition, and timely collaboration with the healthcare provider. Now, looking at the distractors, giving the prescribed analgesic may reduce discomfort, but it would also mask the true severity of the complication without addressing the cause, thereby delaying treatment. Assessing the client's pupil response might seem appropriate, but it is a secondary action and would not reliably identify complications such as acute glaucoma or hemorrhage, especially since pupils may remain altered by dilating drops used during surgery. Repositioning the client on the operative side is unsafe because it can increase intraocular pressure, stress sutures, and delay healing, making the condition even worse. Here is the clinical pearl to remember. Severe eye pain after cataract surgery should always be treated as an abnormal finding and reported immediately. Expected findings include mild discomfort, tearing, or sensitivity to light, while urgent red flags include sudden severe pain, vision loss, flashes of light, purulent drainage, or nausea and vomiting linked to rising intraocular pressure. The NCLEX strategy here is simple but critical. Never mask or delay reporting abnormal findings. Instead, act promptly to prevent blindness. Think of it this way. Do not cover up danger with pain medication. Report first to save sight. Let us begin with this next NCLEX practice question, which focuses on a common yet important aspect of postoperative care following cataract surgery. Before being discharged from the hospital, A client who underwent cataract surgery is instructed by the physician to wear a rigid metal shield, commonly referred to as a fox shield, over the operative eye during sleep. The client then asks the nurse, "Why do I need to wear this shield at night?" Here are the possible responses to consider. The first option suggests that the shield keeps foreign substances out of the eye. The second option states that the shield protects the eye from accidental trauma. The third option indicates that the shield reduces rapid eye movement while dreaming. The fourth option proposes that the shield promotes dilation of the pupil at night. Now, let us carefully identify the correct answer. The most appropriate response is option 2. The shield protects the eye from accidental trauma. The Fox metal eye shield functions as a protective device to safeguard the vulnerable operative site. After cataract surgery, the surgical wound is small but healing, and during sleep, clients may unintentionally rub the eye, press against pillows, or bump the area, leading to increased intraocular pressure, wound disruption, or even extrusion of ocular contents. The shield provides a mechanical barrier against such risks, aligning directly with NCLEX safety and risk reduction principles. Moving on to the other distractors, let us analyze why they are incorrect. Option 1, the shield keeps foreign substances out of the eye, is not the main purpose. While the shield may provide a minor barrier, infection prevention is primarily achieved through eyelids, tear film, and prescribed antibiotic drops. Option 3, the shield reduces rapid eye movement while dreaming, is physiologically impossible because REM cycles are not influenced by an external shield. The eye continues its natural movements. Option 4, the shield promotes dilation of the pupil at night, is also incorrect, since pupil dilation can only be induced pharmacologically with mydriatic or cycloplegic eye drops, not by external devices. To connect this to clinical practice, the shield is specifically recommended for use during sleep and naps when the client has no voluntary control to protect the eye. Nurses must also educate clients to avoid rubbing, bending, heavy lifting, or straining, all of which could increase intraocular pressure and compromise healing. Incorporating this teaching into discharge instructions reflects both evidence-based practice and NCLEX emphasis on postoperative safety, health promotion, and risk reduction. Stand-Coast Pearl. After cataract surgery, think of the Fox shield as the client's personal night guard. It does not block dust or alter physiology, but it stands guard against unintentional trauma when the client is asleep and unable to protect the healing eye. Let us smoothly move into this next NCLEX-style question that focuses on a very common yet high-yield postoperative teaching point. A nurse is providing discharge education to a client who has just undergone cataract extraction with intraocular lens implantation. The question asks, which instruction is most essential to include in the teaching plan to prevent postoperative complications? Here are the possible options. Option 1, avoid bending over from the waist. Option 2, keep both eyes patched at all times. Option 3, sleep with the head slightly elevated. Option 4, expect bleeding to decrease in 1 week. Now, the correct answer here is option 1, avoid bending over from the waist. The reason this instruction is prioritized is because bending forward significantly increases intraocular pressure, which can jeopardize the healing surgical incision. Although cataract surgery involves a small, self-sealing wound, it remains vulnerable during the early recovery period. Activities that raise intraocular pressure, like bending, heavy lifting, coughing, or straining, can dislodge the new lens implant, cause wound dehiscence, or even lead to intraocular hemorrhage. Therefore, teaching clients to bend at the knees while keeping the head upright is a critical safety strategy, typically emphasized for the first 1 to 2 weeks after surgery. On the other hand, let us take a look at why the other options are not correct. Starting with option 2, keeping both eyes patched at all times is unnecessary and potentially dangerous. In modern cataract procedures, clients usually only wear a protective metal or plastic eye shield over the operative eye, especially at night, to prevent accidental rubbing. Bilateral patching increases fall risk and impairs independence, so it is no longer recommended. Moving on to option 3, sleeping with the head slightly elevated is generally safe and may reduce swelling, but it is not the most essential precaution. More important positioning instructions include avoiding pressure on the operative eye and sleeping on the unaffected side. Head elevation does not directly prevent complications related to intraocular pressure or wound security, so while helpful, it is not the priority. Finally, option 4, expecting bleeding to decrease in 1 week, is incorrect. because bleeding after cataract surgery is not a normal or expected finding. Cataract extraction is a minimally invasive, blood-sparing procedure. If bleeding occurs, it may indicate serious complications like suprachoroidal hemorrhage or retinal detachment. Clients should be educated to report any severe pain, sudden loss of vision, or flashes of light, as these require urgent ophthalmologic evaluation. Before we wrap up, let us highlight some quick clinical pearls for NCLEX success. Always remember that safety is the central priority in cataract discharge teaching. No pressure, no strain, and no trauma. Clients should wear their protective Fox shield at night, bend at the knees instead of the waist, and promptly report any unexpected symptoms such as pain, vision loss, or bleeding. Functional vision recovery is usually rapid, but full stabilization can take several weeks. Stand-coast. Pearl. After cataract surgery, think safety first. Bend at the knees, shield the eye, and report the unexpected. No pressure, no strain, and no trauma ensures healing without complications. Hey, stop for a sec. I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package, designed to cover every part of your NCLEX prep. Interactive live classes and easy to watch. Recorded lectures. 5,000 exam-style practice questions, 30 complete practice tests, eBooks, and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail. During comprehensive lecture, this isn't just another review, it's everything you need in one. Please scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Let us transition into the next NCLEX-style practice question, with a clinical scenario that emphasizes safe and effective nursing care. A nurse is caring for an older adult who has recently been diagnosed with chronic open-angle glaucoma. The client reports progressive difficulty noticing objects on either side while walking and frequently bumps into furniture. The question asks, which clinical finding is most consistent with this disorder? Here are the options to consider. Option 1 is persistent itching and burning sensations in the eyes. Option 2 is recurrent headaches during close reading tasks. Option 3 is perception of halos or colored rings around lights. Option 4 is gradual, painless loss of peripheral vision. The correct answer is Option 4, gradual, painless loss of peripheral vision. The hallmark symptom of chronic open-angle glaucoma is a slow and progressive loss of peripheral vision, often called tunnel vision. This results from increased intraocular pressure, generally above 21 millimeters of mercury, which damages optic nerve fibers starting at the periphery. Because this condition is insidious and painless, clients are often unaware until significant vision loss has occurred. It is often referred to as the silent thief of sight. Without prompt detection and treatment, the optic nerve continues to atrophy, potentially leading to irreversible blindness. Screening tests such as tonometry and visual field testing are essential, especially for high-risk groups including older adults, African Americans, individuals with a family history, or those with comorbid conditions such as hypertension and diabetes. Looking at the other options, persistent itching and burning sensations in the eyes do not match glaucoma, but are commonly linked with allergic conjunctivitis, dry eyes, or surface irritants. Moving on to recurrent headaches during close reading tasks, this is more aligned with refractive errors such as presbyopia or hyperopia, where near vision strain causes discomfort, not chronic glaucoma. As for perception of halos or colored rings around lights, that is strongly associated with acute angle closure glaucoma, a sudden and painful emergency marked by corneal edema, severe eye pain, nausea, and vomiting. Very different from the slow, silent progression of open-angle glaucoma. Stand-coast pearl. Always remember, chronic open-angle glaucoma does not announce itself loudly. Instead, it quietly steals side vision first. By the time central vision is affected, significant irreversible damage may already have occurred. Think of it as tunnel vision creeping inward, silently narrowing the client's world. Let us now move forward with another NCLEX-style practice scenario that will sharpen your critical thinking. A nurse is preparing to assist the ophthalmologist during a client's eye examination, and the physician intends to measure intraocular pressure in order to evaluate for suspected glaucoma. The question is, which instrument should the nurse ensure is readily available? Here are the options to consider. Option 1 is an ophthalmoscope. Option 2 is a tonometer. Option 3 is a retinoscope. Option 4 is a speculum. The correct answer is option 2, tonometer. When we look at why option 2 is correct, the tonometer is the gold standard tool for assessing intraocular pressure, which normally ranges from 10 to 21 millimeters of mercury. Elevated pressure is the hallmark of glaucoma, and without detection and management, it causes progressive optic nerve damage and irreversible blindness. Several types of tonometers exist, such as the Goldman applanation tonometer, considered the most accurate, the Schiot's indentation tonometer, and the non-contact air puff tonometer, frequently used for screenings. Accurate measurement not only helps differentiate between open-angle glaucoma, which is painless and insidious, and angle closure glaucoma, which is a sudden emergency, but also guides treatment decisions like topical prostaglandins, beta blockers, or surgical options such as trabeculectomy. Turning to option 1, the ophthalmoscope, this is not correct because it does not measure pressure. Instead, it is used to visualize the retina and optic disc. It can reveal findings such as cupping of the optic disc or pallor, which are secondary effects of glaucoma, but it does not provide pressure values. Moving on to option 3, the retinoscope. This is a tool that helps detect refractive errors like myopia or hyperopia by projecting light and observing reflections, making it irrelevant in diagnosing glaucoma. Finally, option 4, the speculum, is an instrument used to hold the eyelids apart during surgery, such as cataract extraction or foreign body removal, and has no role in measuring intraocular pressure. Here are some high-yield insights to carry with you. Glaucoma results from impaired drainage of aqueous humor through the trabecular meshwork, raising intraocular pressure and damaging the optic nerve. Open-angle glaucoma is nicknamed the silent thief of sight because it progresses painlessly until peripheral vision loss is advanced. Acute angle closure glaucoma, in contrast, presents with severe pain, halos, headache, nausea, and requires emergency intervention. From a nursing perspective, it is critical to ensure that the tonometer is available, prepare the client with topical anesthetic drops if needed, and reassure them that the procedure is quick and painless. Stand coast. Pearl, always remember that glaucoma steals vision silently, and the tonometer is your frontline tool to detect the problem before permanent damage occurs. Let us take this forward into our next NCLEX-style scenario and carefully unfold the reasoning. A 68-year-old client comes to the clinic with a history of untreated primary open-angle glaucoma, and the nurse needs to determine the most characteristic symptom of its chronic progression. Here are the possible options to consider. The first option is tunnel vision. The second option is double vision. The third option is bulging eyes. The fourth option is bloodshot eyes. The correct answer is option 1, tunnel vision. Now, let us expand the rationale behind this choice. Chronic open-angle glaucoma is a progressive optic neuropathy that develops when the aqueous humor cannot properly drain through the trabecular meshwork, leading to a slow rise in intraocular pressure. Over time, this pressure damages the optic nerve head, beginning with subtle loss of peripheral vision. As damage continues, the visual field narrows until the client perceives only the central portion of vision, which is why the term tunnel vision is used. If left untreated, this eventually results in complete blindness. Clients often describe the sensation as looking through a tube or straw, making tunnel vision the hallmark late symptom of untreated glaucoma. Turning to the second option, double vision or diplopia is not associated with glaucoma. Instead, it is usually linked to neurologic conditions, such as cranial nerve palsies, strokes, or muscle imbalances of the extraocular muscles. This symptom reflects misalignment of the eyes and overlapping of images, not peripheral field loss. Therefore, this is not the correct answer. Looking at the third option, bulging eyes, or exophthalmos, is classically associated with Graves's disease due to autoimmune inflammation and orbital tissue expansion. In contrast, glaucoma causes internal damage to the optic nerve and retina rather than altering the external structure of the eye. For this reason, bulging eyes are not a feature of glaucoma. Finally, bloodshot eyes in option 4 can result from conjunctivitis, trauma, allergies, or irritation. While acute angle closure glaucoma can cause sudden redness due to rapid pressure spikes, chronic open-angle glaucoma usually progresses quietly, without obvious redness. Because the question specifically addresses the long-term outcome of untreated chronic glaucoma, bloodshot eyes do not fit as the correct symptom. Before we wrap up, here are some essential NCLEX clinical pearls. Glaucoma is called the silent thief of sight because it is often asymptomatic until significant and irreversible damage occurs, highlighting the importance of regular eye screening in older adults. The normal range of intraocular pressure is between 10 and 21 millimeters of mercury, and values above this increase the risk of optic nerve damage. Early signs include subtle peripheral vision loss and difficulty adapting to low light, while late signs include tunnel vision and eventual blindness. High-risk groups include African American individuals over 40, those with diabetes or hypertension, and those with a family history of glaucoma. A key NCLEX strategy tip is to differentiate conditions by vision patterns. Glaucoma leads to tunnel vision, macular degeneration causes central vision loss, cataracts result in blurred or cloudy vision, and Graves' disease produces exophthalmos. Let us now move into another important NCLEX-style scenario that tests not just recall, but true understanding of client education. A client diagnosed with chronic open-angle glaucoma has been prescribed timolol malate 0.5% ophthalmic solution, 1 drop in each eye daily. During a follow-up visit, the nurse assesses how well the client understands this treatment plan. The question is, which client statement indicates the need for further teaching? Here are the options to consider. The first option is, I must wash my hands before instilling the drops. The second option is, this drug decreases the formation of fluid in my eye. The third option is, I'll need to take this until my eye pressure is normal. And the fourth option is, the cap on the container should be replaced after use. The correct answer here is option 3. I'll need to take this until my eye pressure is normal. This response shows a significant knowledge gap because glaucoma is not a condition that simply goes away once pressure is controlled. Chronic open-angle glaucoma is a progressive optic neuropathy caused by poor aqueous humor drainage, leading to increased intraocular pressure. If untreated, it results in optic nerve damage and permanent vision loss. Timolol malate, being a non-selective beta-adrenergic blocker, reduces aqueous humor production and helps lower intraocular pressure. But it does not cure the disease. Therapy is lifelong unless surgery or laser treatment provides definitive relief. Stopping eye drops once the pressure feels normal risks a dangerous rebound rise in pressure and irreversible blindness. Now, let us clarify why the other options are correct and demonstrate appropriate knowledge. The statement about washing hands before instilling drops, which is option 1, is accurate. Hand hygiene prevents contaminating the dropper tip and reduces infection risk. Next, option 2. This drug decreases the formation of fluid in my eye is correct because timolol blocks beta receptors in the ciliary body to decrease aqueous humor production. Unlike miotics, it does not constrict the pupil but still protects the optic nerve by lowering intraocular pressure. Lastly, option 4. The cap on the container should be replaced after use is also correct. Properly replacing the cap maintains drug sterility, prevents microbial contamination, and preserves potency. Clients should additionally be taught not to touch the tip of the bottle to their eye or any surface. Before we wrap this up, here are some clinical pearls to lock this in for NCLEX success. Always remember that glaucoma equals lifelong therapy, even if the pressure stabilizes. Timolol eye drops, though applied locally, can have systemic effects like bradycardia, hypotension, or bronchospasm, especially in those with asthma or heart disease. That is why teaching punctal occlusion, pressing the inner canthus for 1 to 2 minutes, is vital to reduce systemic absorption. A practical safety tip is advising clients to carry identification noting their use of ophthalmic beta blockers, since these could interfere with emergency care. And finally, an exam strategy. On NCLEX, always flag client statements suggesting that glaucoma treatment is temporary or curative. Chronic open-angle glaucoma is managed, not cured, and missing that fact can cost a client their vision. Let us shift our focus to a critical safety scenario that nurses often face when reviewing medication prescriptions. A nurse is caring for a 72-year-old client admitted with chronic open-angle glaucoma and hypertension, and several new medications have been prescribed. The question is, which medication order would require the nurse to withhold administration and immediately notify the provider? Here are the options. Option 1 is atropine sulfate, also known as saltropine. Option 2 is morphine sulfate, or roxanol. Option 3 is magnesium sulfate, commonly recognized as Epsom salts. And option 4 is ferrous sulfate, which is marketed as Fiasol. The correct answer is option 1, atropine sulfate. Now, let me explain why this is the case. Atropine is an anticholinergic drug that causes mydriasis, or dilation of the pupil, and cycloplegia, which is paralysis of the ciliary muscle. In clients with glaucoma, particularly those with angle closure glaucoma, dilation of the pupil narrows or blocks the iridocorneal angle, reducing aqueous humor outflow. This can trigger a sudden rise in intraocular pressure, leading to an acute angle closure crisis. Even in chronic open-angle glaucoma, anticholinergic medications worsen intraocular pressure and accelerate optic nerve damage. Elevated pressure compresses the optic nerve and retinal blood vessels, causing ischemia, optic neuropathy, and eventually irreversible blindness if not treated. That is why atropine and other anticholinergics are contraindicated in glaucoma, and the nurse must withhold the drug and notify the provider promptly. Moving on to the next option, morphine sulfate. Morphine is an opioid analgesic that acts on the central nervous system to relieve pain. Although it can cause respiratory depression, sedation, and constipation, it does not raise intraocular pressure, so it is not contraindicated in glaucoma. The nurse may need to be cautious in older adults, but there is no glaucoma-related reason to withhold morphine. Looking at the third choice, magnesium sulfate, which many of you may recall is used in conditions like preeclampsia, torsades de pointes, or even as a laxative when taken as Epsom salts. Its action involves smooth muscle relaxation and central nervous system depression. It has no effect on aqueous humor dynamics or the optic nerve. Therefore, it is not harmful in glaucoma clients and does not need to be withheld for this condition. Finally, let us consider ferrous sulfate. This is an iron supplement used to prevent or treat iron deficiency anemia. It has no impact on intraocular pressure, aqueous humor drainage, or optic nerve perfusion. The main nursing points here involve teaching about gastrointestinal side effects and proper timing with food or antacids. From a glaucoma perspective, it is safe and does not require withholding. And here is your stand-coast pearl. Any drug that dilates the pupil can dangerously elevate intraocular pressure in glaucoma. Always screen for anticholinergics like atropine, scopolamine, and certain antihistamines, because giving them to these clients can precipitate sudden blindness. Let us now turn our attention to an ophthalmic emergency that you must recognize quickly on the NCLEX. A nurse is assessing a client with a sudden onset of angle closure glaucoma, and the question is, which assessment finding most strongly indicates that the intraocular pressure has reached a dangerously high level requiring immediate emergency intervention? Here are the options. The first option is spots in the visual field. The second option is severe eye pain. The third option is pinpoint pupils. And the fourth option is bulging eyes. The correct answer is option 2, severe eye pain. Severe, sudden, and excruciating eye pain is the classic hallmark when intraocular pressure in acute angle closure glaucoma rises to dangerous levels. This pain often radiates across the head and is typically accompanied by blurred vision, halos around lights, nausea, vomiting, and rapid loss of vision. The underlying problem is the iris blocking the trabecular meshwork, which prevents normal outflow of aqueous humor. As pressure builds, the optic nerve and retinal vessels are compressed, creating a risk for permanent blindness if not treated quickly. Emergency care involves drugs such as pilocarpine to constrict the pupil and osmotic diuretics like mannitol to rapidly lower pressure, with definitive treatment often requiring a laser iridotomy. Looking at option 1, spots in the visual field are far more typical of retinal detachment, diabetic retinopathy, or hypertensive changes. These are chronic processes and do not reflect the sudden, painful rise in pressure seen in angle closure glaucoma, so this is not correct. Shifting to option 3, pinpoint pupils are more consistent with opioid overdose, organophosphate poisoning, or brainstem injury such as a pontine hemorrhage. In angle closure glaucoma, the pupil is usually mid-dilated and sluggish, so pinpoint pupils would not be expected here. Finally, considering option 4, bulging eyes or proptosis is characteristic of conditions such as Graves's disease or orbital tumors. In glaucoma, the eye does not protrude outward, but instead becomes red, with a cloudy cornea due to edema, which makes this choice incorrect. Here is the clinical insight that you must remember for NCLEX success. Acute angle closure glaucoma is a true emergency, and if untreated, blindness can occur within hours to days. The key triad you must recognize is sudden severe eye pain, halos around lights, and a mid-dilated fixed pupil. Nursing priorities include notifying the provider, preparing to administer intraocular pressure-lowering medications, and maintaining the client in a supine position with slight head elevation to minimize pressure. Contrast this with open-angle glaucoma, which is chronic and painless. Stand-coast. Pearl. Pain plus pressure equals permanent loss. Severe eye pain in glaucoma means dangerously high intraocular pressure that can permanently damage the optic nerve if not addressed immediately. Let us move on to the next question in your script, which highlights an essential comparison that nursing students must master for the NCLEX. A nurse is educating a group of clients about the differences and similarities between primary open-angle glaucoma and acute angle closure glaucoma. The question asks, which statements correctly describe features that are similar between these two conditions? Here are the options for consideration. The first option is that the symptoms appear suddenly. The second option is that the visual field examination demonstrates a loss of vision. The third option is that clients are initially treated with medications. The fourth option is that blurred vision is a common manifestation. The fifth option is that attacks are self-limited but are more harmful with each episode. And the sixth option is that surgery is often required. The correct answers are option 2, option 3, and option 6. Now let us carefully walk through the expanded rationale for each choice, beginning with option 1, which states that symptoms appear suddenly. This is incorrect. Sudden onset of severe ocular pain, halos, nausea, and vomiting is a classic feature of acute angle closure glaucoma, whereas primary open-angle glaucoma develops gradually and is often silent until advanced vision loss occurs. This difference, acute versus insidious onset, is a key NCLEX distinction. Moving on to option 2, which notes that the visual field examination demonstrates a loss of vision, this is correct. Both types ultimately damage the optic nerve, and visual field testing will confirm impairment. The difference lies in timing. Gradual peripheral loss in open-angle glaucoma versus rapid central damage in angle closure. Next, consider option 3, which says clients are initially treated with medications. This is correct because medical therapy is the first-line approach in both. In open-angle glaucoma, medications like beta blockers such as timolol, prostaglandin analogs like latanoprost, or carbonic anhydrase inhibitors are used to lower intraocular pressure. In acute angle closure glaucoma, emergent drugs such as mannitol, acetazolamide, and pilocarpine are administered to quickly reduce intraocular pressure before surgery. Turning to option 4, blurred vision as a common manifestation is incorrect. While it is a hallmark of acute angle closure glaucoma due to corneal edema and sudden intraocular pressure rise, blurred vision is not an early or universal finding in open-angle glaucoma. Instead, clients notice gradual tunnel vision. Let us now evaluate option 5, which says that attacks are self-limited but more harmful with each episode. This is also incorrect. That description applies to recurrent angle closure episodes, which cause progressive optic nerve damage with each painful crisis. Open-angle glaucoma, by contrast, is not episodic, but rather a chronic, progressive disease. Finally, option 6 states that surgery is often required, and this is correct. Both types may require surgical or laser intervention when medications fail. For open-angle glaucoma, procedures like laser trabeculoplasty or trabeculectomy may be needed. For angle closure glaucoma, definitive management usually involves laser peripheral iridotomy to provide an alternate drainage route for aqueous humor. Here is the stand-coast pearl to lock this in. Both conditions lead to vision loss, both start with medication, and both may ultimately require surgery. The major difference is tempo. Open angle creeps silently over years, while angle closure strikes suddenly and can blind within hours. All right, let us move smoothly into the next part of your NCLEX script with this question. After intraocular pressure has been temporarily reduced with osmotic therapy, a client with acute angle closure glaucoma undergoes a surgical iridectomy. During the very first postoperative assessment of the operative eye, the nurse must determine which finding is most expected. Here are the options to consider. Option 1 states that the pupil appears cloudy and gray. Option 2 indicates that the pupil is a fixed size and shape. Option 3 suggests that the entire iris lacks color. Option 4 describes that a section of the iris appears black. The correct answer is option 4, a section of the iris appears black. This outcome is expected following an iridectomy because the surgeon removes or creates a wedge-shaped section of the iris to establish an alternate pathway for aqueous humor drainage. By permitting aqueous fluid to flow from the posterior chamber into the anterior chamber, the procedure effectively prevents pupillary block and future intraocular pressure elevation. The excised portion no longer reflects light like intact iris tissue, so the area looks dark or black. This is a normal and reassuring finding that nurses should document and explain to the client. Now turning to the incorrect options, option 1, where the pupil appears cloudy and gray, is not a normal finding after iridectomy. This description aligns more closely with cataracts due to lens opacity. Postoperatively, if the pupil appears cloudy, the nurse should suspect complications like corneal edema or infection rather than routine healing. Looking at option 2, the idea of a fixed-size pupil is also incorrect. A non-reactive fixed pupil is usually associated with serious neurologic compromise or damage to the iris sphincter muscle. While the pupil may appear slightly irregular in shape due to the surgical wedge, it should still remain reactive after iridectomy. A completely fixed pupil would demand urgent evaluation. Next, option 3, which states that the entire iris lacks color, does not fit this condition either. Complete loss of iris pigmentation would suggest albinism or traumatic iris atrophy, not the result of a localized iridectomy. Because only a portion of the iris is removed, the rest of the iris should maintain its normal coloration. From a clinical reasoning perspective, the purpose of iridectomy is to prevent recurrence of acute angle closure glaucoma by bypassing the pupillary block. Therefore, the expected finding is a black wedge-shaped defect in the iris. The nurse's responsibility is to assess pupil shape, reactivity, and vision while monitoring for red flag complications such as severe eye pain, sudden vision loss, fixed pupil, corneal haze, or purulent drainage. And here is the Stancoast Pearl for memory. After iridectomy, the iris should no longer appear perfectly round. A small black wedge is normal. It is the surgical window for fluid drainage. Cloudy, fixed, or colorless pupils signal complications, not expected healing. The next scenario. A nurse is documenting the health history of a client who presents with sudden onset of visual changes. The client describes flashes of light and a curtain coming down over part of the visual field. The nurse reviews the client's risk factors to determine the most significant predisposing condition for retinal detachment. Which of the following findings in the client's history places the client at the highest risk? Here are the options to consider. Option 1, the client is younger than age 40. Option 2, the client reports a recent fall with head trauma. Option 3, the client has multiple seasonal allergies. And option 4, the client has been receiving treatment for glaucoma. The correct answer is option 2. The client reports a recent fall with head trauma. The reason this is correct is because head trauma is one of the strongest acute precipitants of retinal detachment. Retinal detachment occurs when the neurosensory retina separates from the retinal pigment epithelium. Trauma generates sudden vitreoretinal traction or direct mechanical disruption, leading to tears or breaks in the retina. Once fluid seeps beneath the retinal break, it collects and lifts the sensory retina away, impairing photoreceptor function. Clinically, this manifests as photopsia or flashes, new floaters, or a curtain-like shadow descending across vision. Without immediate treatment, detachment can result in permanent vision loss. On the NCLEX, trauma is considered the red flag risk factor because it is both emergent and preventable. Now, looking at option 1, the client being younger than 40 years old is not a significant risk factor. Retinal detachment is most often seen between ages 50 and 60 when degenerative vitreous changes become more common. Younger clients usually have healthier gelatinous vitreous tissue, and detachment is rare unless they have trauma or high myopia. NCLEX often places this as a trap to test whether you know that older age, not younger age, increases risk. Turning to option 3, multiple seasonal allergies do not predispose a person to retinal detachment. Allergies primarily affect the conjunctiva, causing redness, watery eyes, and itching. They do not disrupt the retina or vitreous structures. NCLEX may include this as a distractor to see if you can separate superficial surface irritation from deeper structural emergencies, like retinal detachment. Finally, option 4, treatment for glaucoma, may sound like a possible answer but is incorrect. Glaucoma primarily damages the optic nerve and leads to progressive visual field loss, but it does not directly cause retinal detachment. In fact, in some cases, the reverse can occur. Retinal detachment may cause a secondary increase in intraocular pressure. The NCLEX uses this option to test whether you can differentiate optic nerve disease from retinal pathology. Here are some clinical pearls to lock this in for your NCLEX success. Classic symptoms include flashes of light, floaters, sudden loss of part of the visual field, or the feeling of a curtain descending. The highest risk factors include trauma, high myopia, prior eye surgeries like cataract extraction, and older age. Retinal detachment is a true emergency, and clients must avoid activities that increase intraocular pressure such as bending, sneezing, or heavy lifting until surgery can be performed. Treatment usually involves surgical repair using procedures like scleral buckle, pneumatic retinopexy, or vitrectomy, with the best prognosis if repaired quickly. Stand-coast. Pearl. Remember, T for trauma, T for tear. Trauma is the most immediate and correct NCLEX answer when asked about risk factors for retinal detachment. Let us smoothly transition into this scenario by focusing on a client with retinal detachment who is awaiting surgical repair. The nurse is about to apply bilateral eye patches, and the key question is, which nursing action ensures therapeutic effectiveness and client safety during this procedure? Here are the options to consider. Option A, occlude all sources of light in the room to minimize retinal stimulation. Option B, apply firm, even pressure with the patches to reduce intraocular tension. Option C, keep the eyelids gently closed under the patches to promote ocular rest. And option D, allow partial vision through transparent patches to reduce client anxiety. The correct answer is option C, keep the eyelids gently closed under the patches to promote ocular rest. The purpose of bilateral eye patching is to minimize involuntary ocular movement and keep the detached retina stable until surgical repair is performed. By keeping the eyelids closed, the nurse prevents blinking, avoids unnecessary strain, and protects the eyes from dryness, dust, or external irritants. Both eyes are patched because eye movements occur in coordination, and patching only one eye would not provide true immobilization. This intervention directly supports retinal stability and reduces the risk of worsening detachment. On the other hand, option A, occluding all sources of light in the room, may sound protective, but does not achieve the primary therapeutic goal. Light itself does not worsen retinal detachment. The problem is mechanical, not light-induced. Therefore, this measure is unnecessary and may even heighten the client's anxiety. Option B, applying firm, even pressure with the patches, is contraindicated because external pressure can increase intraocular pressure, worsen the detachment, or even cause hemorrhage. Safe nursing practice emphasizes avoiding any added stress on the eye. Option D, allowing partial vision through transparent patches, undermines the main therapeutic goal, since even minimal eye movement can destabilize the retina. Although reducing anxiety is important, safety and prevention of harm take priority in NCLEX-style decision-making. Clinically, the nurse should also remember that clients with both eyes patched will have temporary vision loss and require assistance with mobility and activities of daily living. Educating the client and family about the temporary purpose of the patches helps reduce anxiety and promotes safety. From a pathophysiology standpoint, retinal detachment occurs when the neurosensory retina separates from the underlying pigment epithelium, and if worsened, it can lead to permanent vision loss. Here is the Stand-coast pearl to lock in your memory. For retinal detachment, rest the retina, not stress the eye. Both eyes must be patched with eyelids closed, never with pressure, and never with partial vision. Now, shifting our focus to a scenario involving altered sensory perception, let us consider a client diagnosed with retinal detachment who has undergone bilateral eye patching and is on strict bed rest, with the head of the bed slightly elevated. During routine rounding, the nurse delivers a phone message and prepares to leave the room. The key question is, considering the client's visual deprivation and the principle of dignity, which nursing intervention should be prioritized? Here are the options. Option A, straighten the client's linens to ensure comfort and neat appearance. Option B, clearly inform the client that the nurse is leaving the room before exiting. Option C, offer to provide a back rub to reduce discomfort from prolonged immobility. And option D, verbally share recent current events to maintain engagement and reduce isolation. The correct answer is option B, clearly inform the client that the nurse is leaving the room before exiting. Clients with bilateral eye patches experience complete visual deprivation, which creates vulnerability and anxiety. If the nurse leaves without a word, the client has no cue that the interaction has ended, which may cause embarrassment if they continue speaking to an empty room. By announcing departure, the nurse supports psychosocial integrity, respects autonomy, and reinforces dignity. This small but vital act directly addresses Maslow's hierarchy at the esteem and belonging level and aligns with the ANA's Code of Ethics, which emphasizes respect for human dignity. Looking at the other options, although option A, straightening the linens, promotes neatness and physical comfort, it does not address the client's psychological need for orientation and reassurance. Similarly, option C, offering a back rub, can indeed help relieve discomfort and promote relaxation in an immobilized client, but it is optional care and does not target the immediate dignity concern. Finally, option D, sharing current events, may reduce isolation and foster conversation, but it should occur while present, not as the nurse departs. Without announcing departure, it risks increasing frustration and confusion. Clinically, this question integrates psychosocial integrity, sensory alterations, and therapeutic communication, all highly tested domains on the NCLEX. It reminds us that even the simplest nursing actions, such as stating, "I am leaving now," hold powerful implications for dignity, trust, and therapeutic rapport. Standcoast, Pearl. When a client's vision is restricted or eliminated, verbal communication becomes their only orientation cue. Always announce your presence and departure to preserve dignity, reduce anxiety, and maintain trust. Gliding into the next scenario, picture a client with retinal detachment who has been prescribed strict bed rest with both eyes patched and now asks, "I am not experiencing any pain, and I am not dying. Why can I not just get up once to go to the bathroom?" Here are your options to consider in a calm, therapeutic tone. Option 1 says, gravity helps to reattach the separated retina, which is why maintaining strict bed rest is essential. Option 2 warns, you do not want to end up permanently blind, do you? Option 3 offers, if it is difficult for you to remain still, I can request a sedative. Option 4 insists, the physician knows what is best for you, and you should simply follow the orders. Moving to the decision, the correct answer is option 1. Gravity helps to reattach the separated retina, which is why maintaining strict bed rest is essential. And the correct answer is the gravity-based explanation that teaches why immobilization matters. To begin with, option 1 is best because it is accurate, therapeutic, and educational. Retinal detachment involves separation of the sensory retina from the retinal pigment epithelium with potential subretinal fluid accumulation, and before, or in preparation for, surgical repair, strict bed rest and precise positioning reduce ocular motion and vitreoretinal traction, so gravity can help approximate the detached layers. Giving this physiologic why respects autonomy, reduces anxiety, and improves adherence. On the contrary, option 2 is incorrect because it uses fear-based language that can heighten distress and erode trust. Even though blindness is a real risk of progressive detachment, the NCLEX expects nurse responses that inform without threatening, preserve dignity, and support coping in a client already facing visual deprivation from bilateral patches. Furthermore, option 3 is not the priority because reflexively offering a sedative sidesteps the client's request for understanding, introduces avoidable risks such as oversedation and falls, and may mask rather than solve the root issue of inadequate teaching. Education about the purpose of bed rest comes first, and only if needed later should comfort measures or provider-approved medications be considered. Lastly, option 4 is non-therapeutic because it is authoritarian and dismissive, reducing the client to passive obedience instead of a partner in care. The nurse's role is to advocate, explain, and engage the client in informed participation, not to demand compliance. In summary, choose the response that is respectful, informative, and rooted in physiology. Preventing further separation by minimizing eye movement and traction is the immediate priority. And clear teaching about gravity's role in reattachment best promotes safety, adherence, and patient-centered care. And here is the next scenario for your narration. A client has undergone a scleral buckling procedure for retinal detachment, and during the immediate postoperative period, the nurse must prioritize which concern requires urgent intervention. The options include pain, vomiting, anxiety, and fatigue. The correct answer is option 2, vomiting. Now let me explain why vomiting takes priority. A scleral buckle works by indenting the sclera to bring the retina and choroid together, and the surgical repair is extremely delicate. Any sudden spike in intraocular pressure can disrupt the repair and result in loss of vision. Vomiting is dangerous because it causes abrupt increases in intrathoracic and intra-abdominal pressures that transmit to the eye, sharply elevating intraocular pressure. Even one episode of forceful emesis can reopen the retinal tear or cause intraocular hemorrhage. This is why the nurse must act immediately by administering antiemetics such as ondansetron or promethazine, or by promptly notifying the physician if no order exists. On the other hand, while pain is certainly uncomfortable and must be treated with analgesics, it does not directly threaten the integrity of the scleral buckle in the same way vomiting does. Anxiety, though important to address with reassurance or anxiolytics, primarily causes sympathetic responses and mild blood pressure elevations, but not the same acute pressure surges as emesis. Fatigue is the least urgent, as rest can be encouraged over time without any direct risk to the surgical site. When applying NCLEX frameworks like Maslow's hierarchy and the ABCs, the priority is prevention of immediate physiologic harm. Vomiting represents a direct and urgent threat to surgical success and vision preservation, which is why it takes precedence. Here is a Stancoast Pearl to help lock this in. Vision first, pressure last. After retinal surgery, anything that spikes intraocular pressure such as vomiting, coughing, or straining is more dangerous than pain or anxiety. Always treat emesis immediately to protect sight. Let us now move forward into another important NCLEX-style scenario. A client with severe myopia has recently undergone a laser-assisted in situ keratomileusis, or LASIK procedure. During a postoperative teaching session, the nurse needs to evaluate whether the client truly understands the purpose of the surgery. The question asks, which statement by the client provides the best evidence that the teaching has been effective regarding the anticipated outcome of LASIK surgery? Here are the options. First, this surgery will make it easier for me to see better at night. Second, I will finally be able to see colors the way other people do. Third, I should be able to function well without needing corrective eyeglasses. And fourth, I will be able to train my eyes to work together more efficiently when I read. The correct answer is option 3. I should be able to function well without needing corrective eyeglasses. Now, let me explain the reasoning. LASIK, which stands for laser-assisted in situ keratomileusis, is a surgical procedure that permanently reshapes the cornea using an excimer laser. In myopia, the eye is elongated, or the cornea is excessively curved, causing light rays to converge in front of the retina, which blurs distance vision. By flattening and reshaping the corneal curvature, LASIK allows light rays to focus directly on the retina, which improves visual acuity without the need for glasses or contact lenses. Therefore, the most appropriate expectation is reduced or eliminated dependence on corrective lenses, and most clients achieve near 20/20 vision. Looking at the incorrect choices, option 1 about better night vision is a misconception. In fact, night vision can worsen in the early postoperative phase due to glare, halos, or starbursts around lights, which are common temporary side effects of the healing corneal flap. Moving to option 2 about seeing colors normally, this is inaccurate because LASIK does not affect retinal cone cells responsible for color vision. Any inherited color vision deficiencies, like red-green blindness, will remain unchanged after corneal surgery. Finally, option 4 about training eyes to work together is also incorrect. LASIK corrects refractive errors, but does not directly affect binocular vision, convergence issues, or strabismus. Those conditions require different interventions such as vision therapy or prism lenses. To highlight key NCLEX pearls, Remember that LASIK effectively corrects myopia, hyperopia, and astigmatism, but it does not correct presbyopia, which is the age-related loss of near vision after age 40. Patients must also be taught important post-operative care, avoid rubbing the eyes, use prescribed antibiotic and steroid drops, wear protective eye shields at night, and promptly report severe pain, vision loss, or discharge. Side effects may include dry eyes, halos, and fluctuating vision, while rare long-term complications include corneal ectasia, where the cornea thins and bulges forward. Here is the Stan-Coast Pearl. LASIK reshapes the cornea, not the retina, not the nerves, and not the colors. The main benefit is clear vision without glasses. Let us now dive into another NCLEX-style scenario to strengthen your understanding. A nurse in an outpatient clinic is assessing a client who complains of itching, tearing, and redness in the right eye for the past 2 days. On inspection, the nurse notes conjunctival erythema. The question is, which additional finding most strongly supports the diagnosis of acute conjunctivitis? Here are the options to consider. First, crusting and dried mucopurulent drainage along the eyelid margins. Second, loss of pupillary light reflex with unequal pupil size. Third, forward displacement of the eyeball from the orbit, also known as proptosis. And fourth, a dry, dull corneal surface lacking moisture. The correct answer here is option 1, which is crusting and dried mucopurulent drainage along the eyelid margins. Let me explain why this is correct and why the others are not. Conjunctivitis, commonly called pink eye, is an inflammation of the conjunctiva that may be caused by bacterial, viral, allergic, or chemical triggers. In bacterial conjunctivitis, the inflammatory process produces mucopurulent exudate, which dries into a sticky crust on the eyelashes and eyelid margins, especially noticeable after waking up. Alongside conjunctival erythema, this is the hallmark finding that confirms acute conjunctivitis. Looking at option 2, the loss of pupillary light reflex with unequal pupils does not fit. This suggests a serious neurologic or intraocular condition such as acute glaucoma, retinal detachment, or optic nerve compression. Conjunctivitis does not impair pupil function, as it primarily affects only the surface of the eye. Moving to option 3, forward displacement of the eyeball, or proptosis, is seen in orbital cellulitis. Thyroid eye disease, or tumors, conjunctivitis is limited to the conjunctiva and cannot push the eye outward. Now let us consider option 4, a dry corneal surface. This points toward keratoconjunctivitis, SICA, Sjogren's syndrome, or exposure keratopathy. In fact, conjunctivitis usually increases tearing rather than causing dryness. From a nursing perspective, it is vital to teach clients about proper hand hygiene, as bacterial and viral conjunctivitis are highly contagious. Nurses should also stress avoiding the sharing of towels, pillows, or cosmetics. Warm compresses and gentle cleaning of crusted secretions should be encouraged for comfort and hygiene. In cases of bacterial conjunctivitis, topical antibiotics may be prescribed, while antihistamines are used if the cause is allergic. Finally, clients must be instructed to seek urgent medical care if they develop severe pain, sensitivity to light, or decreased vision, as these may indicate keratitis or corneal involvement, which can threaten eyesight. Here is your NCLEX high-yield pearl to lock this in. Conjunctivitis equals a red eye plus discharge with intact vision and normal pupils. Bacterial causes purulent sticky crusts. Viral causes watery discharge. And allergic causes stringy clear discharge with intense itching. And always remember, if pain, abnormal pupils, or vision loss are present, it is no longer simple conjunctivitis, and something more serious must be considered. Kicking off this item with a quick clinical frame, imagine you are discharging a client with acute bacterial conjunctivitis, and you must choose the single instruction that most reduces complications and prevents transmission. Your options are as follows. Option 1, eat a well-balanced, nutritious diet with plenty of fluids. Option 2, always wear dark sunglasses when in bright light. Option 3, do not share towels or washcloths with family members. Option 4, avoid all aspirin-containing products. The correct answer is option 3, do not share towels or washcloths with family members, because bacterial conjunctivitis sheds mucopurulent secretions loaded with organisms, and shared linens, pillowcases, cosmetics, and even eye drop bottles can become contaminated. So using individual items plus frequent, thorough hand washing directly interrupts the hand-to-eye and indirect fomite routes that drive school, household, and community outbreaks. Meanwhile, option 1 is supportive but nonspecific. Good nutrition and hydration aid recovery, yet do not meaningfully curb spread. Likewise, option 2 offers comfort for photophobia only and has no impact on transmission dynamics or the underlying inflammation. Finally, option 4 is irrelevant to conjunctivitis management in most adults. Mild analgesics can be used for discomfort, and the classical aspirin caution pertains to children and adolescents with viral illnesses due to the risk of Ray's syndrome rather than to conjunctivitis specifically. High-yield takeaways for your script. Infection control is the priority. Insist on hand hygiene before and after touching the eyes. Assign separate towels, washcloths, and pillowcases. Advise return to school or daycare only after at least 24 hours of topical antibiotic therapy. Suggest warm compresses to loosen crusts and sunglasses purely for comfort. And add a safety net. If pain, vision changes, or abnormal pupils occur, escalate beyond simple conjunctivitis. Stancoast, Pearl. Conjunctivitis is not just about red, itchy eyes, it is about stopping the spread. So teach no sharing of personal items and strict hand washing first. Let us smoothly transition into this next clinical scenario that tests both ophthalmic knowledge and safety awareness. A nurse is assisting the ophthalmologist during the evaluation of a client who presents with sudden eye pain, tearing, and a sensation of sand in the eye after working with metal tools. The physician orders the application of a diagnostic stain to determine whether a corneal abrasion or embedded foreign body is present. Which solution should the nurse prepare to hand to the physician? Here are the options. Option 1, povidone iodine, also known as betadine. Option 2, gentian violet. Option 3, methylene blue. And option 4, fluorescin. The correct answer is option 4, fluorescin. Now, let me walk you through the expanded rationale step by step. Clients presenting with symptoms such as eye pain, photophobia, tearing, or the sensation of a foreign body require rapid evaluation of corneal integrity. Because the cornea is a vascular but richly innervated, even a minor epithelial break can cause severe discomfort and may progress to ulceration, infection, or vision loss if left untreated. This is why diagnostic stains are commonly used in eye care to highlight epithelial defects under cobalt blue light. Fluorescein is correct because it is a water-soluble dye that selectively adheres to disrupted areas of the corneal epithelium. When illuminated with cobalt blue light, these damaged regions glow bright green, making it the gold standard diagnostic tool for corneal abrasions, ulcers, or detection of embedded foreign bodies. It is also essential in evaluating contact lens injuries, identifying the classic dendritic pattern of herpetic keratitis, and assessing tear film integrity in dry eye conditions. In clinical and emergency practice, fluorescein is quick, safe, and highly reliable, which makes it the only appropriate choice from the list. On the other hand, option 1, povidone iodine or betadine, is incorrect because it is an antiseptic used to reduce microbial load before ocular procedures. It has no staining properties and would further irritate an already injured cornea. Moving to option 2, gentian violet, this is also incorrect. While historically used as an antimicrobial for fungal or candida infections on the skin and mucosa, it is not safe for ocular use and is toxic to corneal tissue. Finally, option 3, methylene blue, is likewise incorrect because it is primarily used in laboratory staining of cells and tissues, not in live ocular assessment, and is not safe for direct use on the cornea. Here's the NCLEX-focused pearl. Remember that fluorescein staining viewed under cobalt blue light is the hallmark diagnostic test for corneal abrasions and foreign body detection. From a safety standpoint, never instill antiseptics or histological dyes like iodine, gentian violet, or methylene blue into the eye, as they damage the delicate epithelial surface. A quick memory trick is this Stancoast pearl, fluorescein for fluorescent findings, because only fluorescein glows under blue light to reveal corneal damage. Lastly, think critically. Any client who reports a sensation of a foreign body in the eye should first be evaluated for a possible penetrating injury. Nurses must never attempt blind removal without physician guidance. The key takeaway for NCLEX is clear. Fluorescein is the only correct agent for corneal staining. All other listed dyes serve different purposes and are unsafe in live corneal tissue. Now, let us move on to a vision-related clinical question that tests your understanding of eye disorders. A nurse is assessing a client with age-related macular degeneration. When the nurse asks the client to describe what they see, which visual change would the client most likely report? Here are the options. First, clear visualization of objects close to the face. Second, the ability to see objects at far distances without distortion. Third, preserved vision of objects in the outer peripheral fields. And fourth, distorted or lost vision of objects in the central field of vision. The correct answer is option 4, distorted or lost vision of objects in the central field of vision. To understand why this is correct, let us review the pathophysiology. The macula is the central portion of the retina responsible for sharp detail and color perception. In macular degeneration, whether the dry type with drusen deposits or the wet type with abnormal neovascularization, the macula deteriorates, leading to loss of central vision. Peripheral vision usually stays intact, but tasks requiring focus, such as reading, driving, and recognizing faces, become severely impaired. Clients often describe a central dark spot, also known as a bullseye scotoma, or distorted lines that look wavy instead of straight. Now, let us carefully analyze why option 4 is the correct choice. Clients with macular degeneration consistently describe trouble seeing directly ahead. They report blurriness, blind spots, or distortion in the center of vision while still retaining side vision. This makes central tasks like threading a needle or reading fine print extremely difficult, which matches the clinical picture of this condition. Next, let us go over why the other options are incorrect. Starting with option 1, clear visualization of objects close to the face is not expected. In fact, near vision is often one of the first to be impaired. Moving to option 2, the ability to see objects at a far distance without distortion is not correct either, because both near and far central vision are lost when the macula is damaged. Looking at option 3, preserved vision of objects in the outer peripheral fields is partly true in the sense that peripheral vision is intact, but the defining feature of macular degeneration is central vision loss, not preserved periphery. To connect this clinically, remember that there are 2 types of age-related macular degeneration. Dry AMD is more common and progresses slowly due to retinal thinning and drusen accumulation. Wet age-related macular degeneration is less common but more severe, involving abnormal blood vessel growth that leaks and causes rapid vision loss. Risk factors include age above 60, smoking, hypertension, obesity, low antioxidant intake, and family history. From a nursing perspective, it is vital to assess how vision loss affects daily functioning. Provide resources such as magnifiers and adaptive lighting, teach clients to rely more on their side vision, and reinforce the importance of regular follow-up with ophthalmology. Treatments like anti-VEGF injections for wet AMD can help slow progression and preserve what vision remains. And here is your high-yield Stand-Coast pearl. Macula equals middle vision. When the macula degenerates, the middle central vision disappears, but side vision stays. Clients may even tell you, "I can see the outline of your face, but not your eyes." Let us now move to another important NCLEX-style scenario that highlights preventive health teaching for older adult clients. A community health nurse is making home visits to older adults with chronic conditions and wants to stress the importance of regular ophthalmologic examinations. The question asks, which client is at the greatest risk for developing progressive, vision-threatening complications that warrant routine evaluation by an ophthalmologist? Here are the options to consider. The first option is a client taking low-dose aspirin daily for cardiovascular protection. The second option is a client with a 12-year history of poorly controlled type 2 diabetes mellitus. The third option is a client who is lactose intolerant and avoids dairy products. And the fourth option is a client living with a permanent pacemaker for atrial fibrillation. The correct answer is option 2, a client with a 12-year history of poorly controlled type 2 diabetes mellitus. Let us carefully walk through the reasoning behind this. Diabetes mellitus is one of the leading causes of preventable blindness worldwide. Long-term exposure to high blood glucose damages the microvasculature of the retina, producing diabetic retinopathy. Early stages may show microaneurysms, hemorrhages, or cotton wool spots, and advanced stages may progress to neovascularization, vitreous hemorrhage, or retinal detachment. Because this damage can develop silently and remain asymptomatic until late, annual dilated eye exams are essential for detection. If changes are caught early, interventions such as laser photocoagulation or intravitreal anti-VEGF therapy can prevent severe vision loss. This makes the diabetic client the highest risk case requiring strict ophthalmology follow-up. Now, considering why the other options are incorrect, low-dose aspirin, as in option 1, might increase bleeding tendencies, but it does not independently cause retinal vascular disease or blindness, so specialized ophthalmology referral is not required. Option 3, lactose intolerance, is primarily a gastrointestinal issue. While avoidance of dairy can affect calcium and vitamin D levels, it has no direct link to progressive vision loss. Option 4, a pacemaker, is designed to correct electrical conduction problems of the heart and does not directly impact retinal health or perfusion. To tie this all together, here are some high-yield pearls. Clients with diabetes should begin annual dilated retinal exams at diagnosis for type 2 diabetes and within 5 years of diagnosis for type 1 diabetes. Tight blood glucose, blood pressure, and lipid control all reduce microvascular complications, including retinopathy, and always remember the rule of microvascular damage in diabetes. The organs at greatest risk are the eyes, kidneys, and nerves. So, the critical teaching point here is, diabetes equals microvascular damage, and early ophthalmology referral saves vision. Moving on to another high-yield scenario, let us focus on a client with a malignant ocular melanoma who has agreed to undergo enucleation of the eye. The nurse provides postoperative teaching and wants to evaluate the client's understanding of what to expect. The question asks, which statement reflects the most accurate understanding of the surgery? Here are the possibilities to consider. Option 1 says, "My vision will be restored with a plastic prosthesis." Option 2 states, "The prosthetic eye will be inserted during surgery." Option 3 explains, "I will need to remove my prosthesis periodically for cleaning." And option 4 claims, "I will have a permanently empty eye socket." The correct answer is option 3. "I will need to remove my prosthesis periodically for cleaning." Now let us carefully unpack the reasoning behind this choice. Enucleation is the surgical removal of the eyeball itself while leaving the surrounding orbital structures intact. It is commonly performed for intraocular malignancies, severe trauma, or blind, painful eyes. At the time of surgery, a conformer or orbital implant is placed to preserve socket shape and prevent tissue contraction. But the final cosmetic prosthesis is not inserted until healing is complete, usually in 4 to 6 weeks. Once fitted, the prosthetic eye is purely cosmetic, restoring appearance but never restoring vision. Clients are educated to periodically remove it for cleaning, which helps prevent infection, irritation, and accumulation of secretions. Let us examine why the other options are incorrect. Beginning with option 1, the idea that vision will be restored with a plastic prosthesis is a misconception. Once the eyeball and optic nerve are removed, sight cannot return. The prosthesis only serves cosmetic purposes. Shifting to option 2, it is inaccurate to believe that the prosthetic eye is inserted during surgery. In reality, only a conformer is placed initially, with the final custom prosthesis fitted later after proper healing. Lastly, option 4 suggests a permanently empty eye socket, which is not correct. The client will not be left with an empty socket since the conformer is placed at surgery and later replaced with the artificial eye to give a natural appearance. From a nursing perspective, post-operative care involves monitoring for bleeding, infection, and implant complications, while also addressing the psychological impact of eye loss. Emotional support and teaching about prosthetic handling are critical, as is long-term follow-up with the ocularist for fit and socket health. Here is your Stan Coast Pearl. Conformer first, prosthesis later. Always remember that the conformer preserves the shape of the socket during healing, while the prosthetic eye is introduced weeks afterward, serving only cosmetic, not visual, restoration. Let us transition into another important NCLEX-style scenario to strengthen your preparation. Imagine a client who is 3 weeks post-penetrating keratoplasty, also known as corneal transplant, performed for advanced keratoconus. During a routine clinic follow-up, the client says, "I have noticed something unusual in my operated eye." The nurse must carefully evaluate this statement to identify whether it indicates a sign of graft rejection. The question is, which client statement would raise the highest concern for graft rejection requiring immediate intervention? Here are the possible options. Option 1, my operated eye keeps watering excessively. Option 2, I feel like I need to blink more often than usual. Option 3, I am experiencing more itching in my eye lately. And option 4, my vision in the transplanted eye seems to be getting worse. The correct answer is option 4, my vision in the transplanted eye seems to be getting worse. Now, let us explore the reasoning behind this choice. A corneal transplant, or penetrating keratoplasty, involves replacing a diseased or scarred cornea with healthy donor tissue. It is commonly performed for keratoconus, corneal scarring after trauma or infections, or severe corneal opacities. While most clients experience good outcomes, the most serious complication is graft rejection, where the immune system attacks the donor cornea as foreign tissue. Nurses remember the signs of rejection with the RSVP mnemonic: R for redness, S for sensitivity to light, V for vision decrease, and P for pain. Among these, vision loss is the most critical early warning sign because it signals that the corneal graft is being compromised. Loss of clarity occurs due to inflammation, stromal edema, or endothelial rejection. If caught quickly, treatment with corticosteroid eye drops or systemic therapy may reverse rejection and save the graft. Looking more closely at the options, excessive tearing, as in option 1, may simply reflect irritation or dryness, but is not diagnostic of rejection. Frequent blinking in option 2 often results from surface irritation or dryness and is nonspecific. Itching, as in option 3, usually relates to allergies or dry eye syndrome rather than graft failure. Only option 4, worsening vision, directly signals graft rejection and therefore requires immediate attention. In terms of clinical action, the nurse must treat vision loss as an emergency, promptly notify the ophthalmologist, and teach the client to report any RSVP symptoms without delay. Delay in intervention can result in graft failure and permanent vision loss. Here is a high-yield pearl for NCLEX. Remember RSVP, redness, sensitivity to light, vision decrease, and pain, as the cardinal warning signs of graft rejection. Prioritize functional loss over discomfort symptoms. In corneal transplant patients, a complaint of worsening vision always takes precedence. Stand coast. Pearl. In eye care, loss of vision is never taken lightly. When a client with a corneal transplant says their vision is getting worse, treat it as the most urgent red flag over all other minor complaint. Thank you. We will see you in next video.